You can have everyone stand for the Pledge of Allegiance. Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, liberty and justice for all. If I could ask all of you to just remain standing for a minute. We did lose Dr. D. Taglier, who is a longstanding member of SEMAC and medical director. If we could have a moment of silence for him. Okay, thank you all. We'll ask if you do speak, if you could please mention your name as you start speaking for the transcriber so we can have the meeting transcribed appropriately. Valerie, if we can have the roll call.
Dr. Bart. Dr. Berkowitz. Dr. Berry. Dr. Bombard.
Dr. Bombard here.
Dr. Cooper.
Here.
Dr. Cushman. Dr. Daly. Dr. Doynow. Dr. Gomez. Dr. Isaacs.
Here.
Dr. Kugler. Dr. Lynch.
Here.
Dr. Markowitz. Dr. Maynard. Dr. Marshall.
Present.
Dr. Murphy. Dr. Olson.
Olson here.
Dr. Talbot. Dr. Walters.
Walters here.
Dr. Wislinski. Dr. Winslow.
Present.
And the non-voting members, Orrin Barzilay. Aiden O'Connor. Mark Philippi.
Philippi present.
Marianne Portoro. Dr. Raybridge.
Here. Here.
Mike McAvoy.
Here.
Steve Kroll.
Present.
And John Washko.
Present.
Do we have a quorum, Val?
Yes, we have a quorum.
Excellent, thank you. Can we have approval of the previous meeting's minutes? Would anybody like to make that motion?
So second.
Okay, Dr. Cooper, Dr. Marshall, all in favor? Anybody against? Okay, so passed. Okay, Ryan, Bureau Staff Report.
Good morning, everyone. I'll try and be brief and going to focus on two primary things and go from there. In operations, we continue on with operations. Just a reminder to everybody, make sure to have your inspections in. One of the biggest things with both operations and education is the new EMS forms page is live. So if you go to Bureau website, you go to EMS forms, there's a drop down. It's separated by operations, education, Part 18s. It is all centralized there. So I encourage everybody to use that if you need to submit any forms. We are very excited to go from literally getting buckets of mail every day to, enough that you can walk with it under your arm. So thank you also to everybody here who has helped with that part. It is a new system, so please, if you see anything that doesn't look right or something that needs to be fixed, by all means, feel free to provide that feedback to us. We continue to execute our contracts on the PA side and on the SEMSCO side. Thank you for everyone who's doing that. If anybody's having any issues with that, again, please make sure to come forward. This is also, really important too, to make sure that there's timely submission of invoices, both for program agencies, for SEMSCOs, for core sponsors, so that we can appropriately make sure that funding that's allocated for the year is spent in that year. So if anybody is holding on any funding with their core sponsors, the program agencies, or their REMSCOs that can be submitted. Please make sure to submit that honestly within the next 2 weeks so that it falls into this fiscal year. Education-wise, we're moving into some new applications. We have renewal paperwork that will be going out. There is a PSC that will be discussed, I think, later, the beta test on the PSC. We're excited about that one, and some updates on the regional faculty process, as well as some online training now for regional faculty members. Data and informatics, doing lots of good things, moving things forward. There's also been some feedback from multiple committees over the past 2 days to talk about how often updates happen with data and informatics and seeing what we can do to reduce the number of updates that happen while still meeting the needs and meeting NEMSIS standards. So we'll be working with that side to do that one. We'll be in Syracuse for Vital Signs October 17th to the 22nd, and there is currently a call for presenters. So particularly to all our physicians and our local ones to Syracuse, please go ahead online to the Vital Signs Conference website and submit to be part of this year's conference. The memorial, we have, and Val, please confirm, is it 7 or 8? It's 7 names? We have 8 names that will be going up on the memorial this year. It will be the same memorial as you've seen in the past. We are working on the new one, and that is just showing to be, it's going to take longer than expected to get there, but it will be done right, so we're patient with that one. That will be in May, so please join us in May for the EMS Memorial. The OASIS grant continues on, doing lots of good things around the state with Jenny and her team, and as well as the regulations. So regulations have cleared some of the initial processes, and this is important. We hope that between this meeting and the May meeting, the regulations for both education and operations will go out for public comment. So education and operations will go out for public comment. That's work that has come from this committee or from the governing bodies here, the state councils, and it will go out for public comment. Once it goes out for public comment, if there's no public comment or no opposition, it will come back to the SEMSCO for final approval and then turned into reg. But during public comment is also the opportunity for everybody here to comment, and also to comment for the positive as well. So to go on and be able to see it. We will make sure to share it widely. We encourage you to share it also, with others, and to please make sure to comment, even if that comment is, we support. They do look at that as well. So it's not just, things in that nature in the negative. So again, between now and May, hopefully that will be out. If by chance it gets out for a 60-day period and there are no comments of opposition or no changes that need to be made, it could be something that we'll be voting on as early as the May meeting, but we won't be able to tell until it actually goes up for public comment. Most realistically, my guess is it will probably be open during the May meeting. It will then close. We'll do any edits that need to happen. It might have to go back out for public comment again, and then it would be voted on at the September meeting. Anything that has a timeline to it in there is based on the date that the regs are published. So there's not a date in there that will say these will go live on December 31st. It is based on 6 months from the data publish or so on and so forth. So just understanding on that side as well. Last 2 things. I know it's going to be spoken about, I think, at this committee as well. Correct me if I'm wrong. But the EMS sustainability study. You, all as members, have received the EMS sustainability study in your packet of information. It is also up on our website under the meeting documents. We are really excited about this document. I want to applaud all the members, both from this council and the state council and from around the state who were part of that, as well as Chief Benedotti for starting all in a parking lot and a conversation of some thoughts and spending the past year putting together this 70-page white paper with 25 significant recommendations at the start of it. And so the work that has been done to put this together and to make advisement and to improve the EMS system and to put it on paper, and to put it on paper for both EMS providers, but also for people who are not a part of the EMS community to understand what those problems are, absolutely incredible. So thank you to everybody who was a part of that committee. I encourage everybody here to please not only read it, but to comment about it, discuss it, bring it forward, bring it to your REMSCOs, there's, very, very excited about it. The second part on that is actually the timing is very interesting. Yesterday, we had our first Rural Health EMS Task Force meeting. This is an action from a legislative action, or a task force that was set up from a legislative action. There was a copy, I believe, of all the membership of the committee members for the Rural Health EMS Task Force in your packet of materials. And they had their first meeting yesterday to discuss the issues of EMS in rural settings. They will be meeting now for the next year and hopefully really taking the EMS sustainability study and taking it to the next level as it relates to the EMS community, and then making recommendations to the elected bodies on how to improve EMS in the rural settings. Last but far from least, I want to talk about just for a minute, and I think we're going to talk later in this meeting about it, is the budget. And the amount EMS is mentioned in the budget and supported in the budget, and new initiatives and changes to improve. I think when I was looking over the EMS sustainability study, there were about 15 of the 25 recommendations that would be affected, whether it be in full or in part, with the changes that would come from the budget from this year. So again, exciting to see things line up, exciting to see feedback from this council and the SEMSCO from last year as Part F, and seeing it in Part S this year. So again, really excited to see those things. I welcome all feedback, thoughts, comments, likes, dislikes, recommendations. I can't change anything in the budget, but I'm happy to share information, share where the positive is, share where the challenges are, and so that we can, move forward. There's a tremendous amount of really great things in that budget this year, and in the legislation that along with it, and we're really excited to see that hopefully move forward. With that, that's the end of my report.
Thank you, Ryan. Moving on to subcommittees, Med Standards, Dr. Marshall.
Thank you, and good morning. Still morning, we have time. So Med Standards met earlier today, and while we started off with zero motions, we wound up with 4. I don't know how that happened. So we have 4 motions that come forward to this body for a decision, and I'll just the first one was for the past couple of meetings we've been discussing the protocol change policy, and some revisions were made recently, and there was no further discussion on it, so the motion comes forward to approve the protocol change policy. That was unanimous decision. When it comes to this body, it's not a protocol change, so I don't think you need to do a roll call vote.
I don't think we need a roll call. Probably just let's put it this way, anybody against this policy? Any abstentions? I'll assume everybody's in favor, so that passes. Or we can have everybody raise their hands. Everybody in favor?
No, it's better the first way. Now you can say it's unanimous, as if you took a roll call.
Okay. Thank you, Dr. Nostrom. We'll do it the first way. All right, so it's unanimous. It's passed. Let's move on.
Okay. So the next motion is to accept the collaborative protocols as the state BLS protocols, excluding cities of 1 million or more.
Any discussion on this? Okay. Anybody against? Anybody abstaining? We'll assume it's unanimous. It's passed.
Okay. The third motion that comes forward is to approve the medical device advisory that was sent out recently. And I think that the reason for this medical device advisory was to make sure that an agency medical director knows what medical devices are being used and actually approves them for the agency.
Any discussion? Anybody against? Anybody abstaining? Again, unanimous. Guys really have it together today.
Yeah, we're working as a team. Okay. And the fourth motion is actually a protocol change that was brought forward. We have some discussion on super SGA for AMT, and on page, what? Yeah. Yeah. If you look at, if you have the collaborative protocols, I think on page, Dr. Daly, please jump in, on page 182, top of 182, where it says alternative airway device in unresponsive adults, changing that to patients, the word adult to patient. And then at the bottom of the page, it also says if equipped and trained, and that would permit AMTs to use SGA in unresponsive patients.
Yeah, the exact change is removal of the word adults, replacement with the word patients with an asterisk next to it for coordinating with the if equipped and trained at the bottom.
Thank you for the clarification.
That, I assume, will require a roll call vote, as it's a protocol change.
Dr. Berkowitz. Yes. Okay. Dr. Bombard.
Yes.
Dr. Cooper. Yes. Dr. Cushman.
Cushman, yes.
Dr. Daly. Yes. Dr. Doynow. Yes. Dr. Isaacs.
Yes.
Dr. Lynch.
Yes.
Dr. Markowitz. Dr. Marshall.
Yes?
Dr. Olson.
Olson, yes.
Dr. Talbot. Yes. Dr. Walters.
Walters, yes.
And Dr. Winslow.
Yes.
Motion passes.
So, thank you. There were some other items that were discussed, and we talked about last time transport of the newborn and neonate. We actually had a demonstration of some devices that can be used to transport newborns and neonates with the mother in a safe manner, which is, as was pointed out this morning, we are probably not transporting neonates and newborns as safely as we could. So the description of those items are available on the EMSC website, maybe? I forget.
Thank you.
Information on safe transport of pediatric patients can be found on the New York State EMSC resources page. Alternately, you can look on the SEMSCO Pediatric Emergency Council page, and there's a special section on the SEMSCO website for safe transport of pediatric patients. Also, if you want more information or more specific details, you can email me, Amy Eisenhower, so amy.eisenhower@health.ny.gov, and I'll be happy to help.
Thank you, Amy.
We also had an update. At the last meeting, we had asked for some data on pediatric patients under the age of 3. And so we do have some data from 2021 and 2022 that I think is worth sharing. In 2021, there were 18,259 pediatric patients that were transported, and EMS providers documented the weight in 92% of those, which is really phenomenal. 12% of the 18,000 received at least one medication, and the top 5 medications are oxygen, albuterol, Atrovent, midazolam, and Decadron. And in 2022, there was actually a 38% increase in the number of pediatric transports to 25,154. That's a significant increase, and weight documented in 98% of those patients. So our providers are doing a phenomenal job of documenting weight in pediatric patients. Again, 14% received at least one medication, and that was oxygen, albuterol, Atrovent, midazolam, and albuterol ipratropium combination. So as we are able to get more data, if there are requests for additional data, please let us know so we can bring it back and share it with everybody.
Dr. Marshall?
Yes.
Can I just make a clarification on that? So that data that you just read off was for newborn to 3-year-olds,
Yeah.
not for all pediatric patients,
Correct.
just
Yeah.
for those
Yeah.
out there watching.
Oh, okay.
Thanks.
Thank you. All right. The other thing we had a discussion on is the medication assist protocol. We have a SEMAC policy. It's 0407, but there are some changes in the collaborative protocol. So the department and I will look at that and then bring it back to the next meeting in May for discussion. We also talked about participation in the CARES program, which is the cardiac arrest registry to enhance survival. And Director Greenberg had mentioned revising a letter that went out a while back, also encouraging EMS providers and hospitals and others to participate in registries. And so for those who may not know, this one is to help save more lives from out-of-hospital cardiac arrest, strengthen collaboration between 911, first responders, EMS agencies, and hospitals, and allow us to generate reports for benchmarking within our regions and our state, which we think will be very helpful moving forward. So the department will be looking at the previous letter and revising it and reissuing it. So that should help support our participation in that program. The other thing I'd like to just quickly mention, well, two things. We had a very long and really great discussion on credentialing of ALS providers by regions, what that means and what it doesn't mean, what are the benefits of doing it at the local level, and also talked about the process of taking away credentialing and where that authority lies with the department. And so it was a very good discussion. We didn't resolve anything, but I think that the sense that I get from the group is that all regions need to have some authority over their ALS providers. And we're not talking about the bad actors. The bad actors that need to be reported to the department should be reported to the department. We talked a lot about quality issues and quality of care, and what do you do with in the region for the individual who misses every intubation. I mean, how do you deal with that? So we had that discussion as well, and I think that discussion will continue going forward. And the last thing I'd like to, and if anybody wants to comment on that as well, I see Dr. Daly's light is on. The last thing I'd like to mention, and then Dr. Daly can take over, is Dr. Cooper had mentioned utilizing just culture in EMS, and I know that most hospitals are using just culture now when we look at what we do. And so I think that was a very good idea, and I would encourage all agencies to learn about just culture and incorporate that in your processes. And Dr. Daly?
Actually, I was going to comment on something you'd mentioned before, which is the prescribed medication assistance. Just for this body to remember, this was a protocol that was developed specifically to assist patients across New York State with rare diseases. One of the things that came out at the National Association of EMS Physicians, as I interacted with some folks there, they were lobbying specifically 2 states to make sure that this was an option available to their EMS providers, was that while New York had not done a particularly good job of educating all of our providers to this protocol, we stand not quite alone, but with very few other states, as to give this option to patients with rare disease and to our EMS providers to assist them. So this body and obviously the state council, but state EMS as a whole, is to be complimented for being on the cutting edge of taking care of patients with rare diseases and making sure that we have these kinds of options out there. So, thank you all.
Thank you. I would just refer people to the medical standards minutes when they come out for a further review of the credentialing discussion. I think is really good. So, and that's my report. Thank you.
Thank you, Dr. Marshall. Thank you, Dr. Daly. Education.
Mike McAvoy, I'm the chair currently of Education and Training. Don Hudson is going to take that committee over for me after this meeting, I think. He's roaring ready to go. Staff report gave some statistics for last year in New York State. We had 10,756 students come through courses. 892 of those were CFRs, 8,972 were EMTs, 203 AEMTs, and 689 medics. The reciprocity folks did 1,200 reciprocity applications and issued 750 reciprocity certificates, primarily EMT ones. They denied 140. Most of those denials had to do with imbalance in class hours versus virtual time. And then they did some analysis of using a program called Tableau, which looks at trends over a 10-year time period of EMT courses that are run and sponsors. And basically, one of the things that they saw is over the last 10 years, there's been very little change in the numbers of providers that we've graduated from our courses. Despite the fact that that number seems to have dipped in other places around the country, there's been a little spike in the last 2 years in paramedics who are graduating from courses. And course sponsors, over a look for the last few years, have also not changed significantly. The same numbers of course sponsors exist across the state. There are 2 new PSI electronic testing sites that have opened, one in Burlington, I think Vermont, and the other in Erie, Pennsylvania. And while that may seem odd to give New York State exams out of state, those serve some rural areas of the state that have difficulty accessing testing centers. One of the things we reported on at the last meeting was the revisions to the BLS practical skills exam, and we did a little bit of a trial with that. We have another one coming up shortly at one of the course sponsors downstate, and the general finding from that is that while the exam is significantly different, testing people's critical thinking ability, more so than just their ability to do skills, it's going to create a comprehensive need to update instructors, update students, update examiners. And so that process, rather than happening instantaneously this year, as we planned, is probably going to occur over the course of the next 2 years. One of the things that we're collecting data on currently with the experimental application of that is revisions to the manual, which are being done through Boardable by the Bureau and the training and ed staff, as well as the cost, the financial aspects of administering that exam. And that will get incorporated in with some new budget planning. We did speak with the Finance Committee, and we're going to have a joint work group of people from training and ed and finance to actually take a look at the course sponsor surveys and come up with some suggestions for adjustments in the rates that are reimbursed by the Bureau, and perhaps some of the policies as to who can be reimbursed for versus not, and other things that have to do with the finances pertaining to courses run for EMS providers. There was also 2 work groups that we established in addition to that finance group. One is going to take a look specifically at instructor recertification, and this discussion came up at the last SEMSCO meeting, and that was to talk a little bit more about whether our requirements for instructor certification and recertification are actually contemporary or not, whether those could use some revision. They'll probably also take a look at some of the issues that have to do with reciprocity for out-of-state instructors who are coming into New York. So that was one group that was put together. And the other one was the finance work group. We also asked the Bureau last meeting if they could give us some information about a process they use called Zendesk, which are help tickets that are submitted for the electronic exams. And it depends on who you talk to. People have varying stories about how well the testing vendor is interacting with the Bureau and how efficient it is. It turns out that roughly 2% of the exams that are administered result in a problem. And so we're going to get some regular reporting from the Bureau of what those issues are. They seem to be primarily related to interface between the testing vendor and the Bureau's computer system, where scores don't transfer over as readily as they need to be. The other thing that happens is scheduling assistance problems, and those comprise most of the 2% of problems that occur. So two things we got out of that. One is we could do a little bit better with the scheduling processes, and the Bureau is about to open up a method where course sponsors can actually pre-register their students at the end of a course, and that will help to get people to take the exam rather than getting an email a week later saying, take this test sometime in the next year. So I think that will help a little bit. There are some sponsors who are actually currently pre-registering their students and paying for them to take the test, which also seems to encourage them to take it a little bit more promptly. The other thing that we got from that is that of all of these problems that are occurring, it would seem as though they're small. It's not a big, huge issue with the vendor, and they're things that one by one the Bureau has been able to fix. They did post a new page on the education website, which talks about what a student needs to do to take the exam, and email that a student can reach out to if they have a problem with the exam. And most of us who have looked at that page have found that the 6 most stupid questions that anyone ever asks us are all answered on that page. And so somebody who goes there could quickly find out what they need to know about a problem that they're having with the exam. So that's a very helpful resource that was put in place. And I think the other thing that we had some discussion about, just to mention it here, is funding for courses and the ability of paramedic courses to have Excelsior funding when that program is actually labeled as a certificate program rather than just a program. And if it's an official SUNY approved program and it's a certificate or an associate's degree, it's fairly simple for a student who's eligible financially to get full funding for that training. There also is money available through the New York State Jobs Funding administered by each county that could pay for both paramedic training, advanced EMT training, and EMT training. So we're going to do some more exploration of those things and see if we can aggregate some of that data and perhaps put that together in a format that we could distribute to course sponsors so that they're a little bit more aware of it. And Howard Hughes is going to work with some of his colleagues to put that together. So unless there are any questions, that's the training and ed report.
Any questions? Thank you, Dr. McAvoy. Sure, go ahead, Mark.
So separate from training and ed, but I think important for this group as well, we had a meeting with the paramedic directors last night, myself and the education team. A lot of great discussions on paramedic education and a number of different items. One of the big ones was the field training and having a standardized field training officer program, both a training program and the curriculum, as well as a program guide. And so that's an initiative that the paramedic program directors said that they'd be very open to helping us with. It's part of their accreditation is to have a field training program, and to have their students mentored. And I know many of you are paramedic program directors or medical directors. So just wanted to bring that one up, and I think training and ed will see that coming forward at the next meeting as well. But an exciting, opportunity for many.
Thank you, Ryan. Dr. Cooper, EMSC.
Thank you, Dr. Doynow. EMSC met recently, and a rather full agenda. First, want to report that the Pediatric Emergency Care Coordinator Survey is out for all EMS agencies to complete. And the Pediatric Emergency Care Coordinator Survey for emergency departments has closed. The response rate given COVID was probably not as robust as had been hoped for, but there is information about that on the EMSC EIIC website, the Texas group that staffs the Innovation and Improvement Center for EMSC. In between our last meeting and this, the Pediatric Agitation Group met, and it was largely determined that pretty robust education was going to be required in order to implement a system whereby psychological de-escalation was the mainstay of care, at least for the younger children. Efforts are being made to actually introduce that or develop and introduce that education. There are already excellent materials on the EIIC website again. This information was actually shared with the emergency medicine community through the ACEP newsletter late last year. A big spread on that in that particular publication. So I'm presuming most of you as emergency medicine physicians received that publication and either had or will have the opportunity to review that information for yourselves. It is our hope that there will be something about pediatric agitation and de-escalation techniques on the vital signs program in the fall, and probably something as well on the learning management system, the EMS Academy sponsored by the Bureau. The trauma triage group also met and focused on, again, the thought that what was needed rather than protocol change was education about the various additional changes that were made in this edition of the National Trauma Triage Guidelines. Probably the key issues in that document, aside from the formatting of it, are the inclusion of several criteria that suggest examples of additional concerns that might cause a provider to want to transfer a patient who does not otherwise meet physiologic, anatomic, or mechanistic criteria to a trauma center. In addition, as many of you are aware, sort of a stripped-down version of the shock index has been added to the physiologic criteria, and all of this probably requires some degree of education for our pre-hospital providers, and so we'll EMSC in collaboration with the STAC will be working on that project. Those of you that had the opportunity to attend medical standards earlier today had the opportunity to view Amy Eisenhower, Ryan Greenberg, and Mike Daly demonstrating some of the new pediatric and neonatal transport devices that are available. There will be a subgroup of EMSC that will be reviewing the available information on these devices. Of course, Amy's predecessor in the role of EMSC Program Manager for the Bureau, Martha Golke, had spent quite a bit of her time focusing on the child passenger safety technician issues and all things transport. Amy has considered that in high style and is a very active member of the National Association of EMS Officials subgroup, which is focusing on pediatric transport Amy's major contribution to that has been making sure that neonates are appropriately addressed in that process. Last but not least, an issue arose at the last SEMAC meeting about the possibility of incorporating high-flow nasal cannula into pediatric transport. The group that discussed this pretty universally felt that there was quite a limited role, if any role, for high-flow nasal cannula in pediatric patients, particularly in short-term urban environments. As most of you know, use of high-flow nasal cannula really uses up your oxygen resources in rather quick order. But it was noted during that series of conversations that high-flow nasal cannula may have a role, and in fact is being used with some frequency during interfacility transport, mostly by critical care transport teams from receiving hospitals, pediatric receiving hospitals, teams that are staffed largely by physicians and nurses. But then the question arose, well, what if we're talking about a circumstance where there are paramedics involved in that critical care transport on an interfacility basis? What's the role there? All present recognized that we had not really taken a deep dive into the interfacility issue with respect to, our advanced life support providers in some years. Many of you remember that Dr. Deborah Funk, emergency medicine physician from the Albany area, led a task force for the State Council, which focused in large measure on air ambulance issues. But there are significant ground transport issues as well. And so the thought came from the group that discussed these issues that perhaps it was high time that we get together a group involving experts from both SEMAC and EMSC to look at the broader issue of interfacility transport overall, and the potential role of certified EMS professionals in that realm. So I spoke with Dr. Doino about this. Dr. Doino is in agreement that this is perhaps something we should consider, and he asked me to bring it up here to get some feedback from the group. Speaking for EMSC, I think we would be very, very interested in revisiting this issue. We're particularly concerned about the role of advanced life support providers assisting with pediatric transports between facilities. Complicated issue, as you know, because we're talking about, in many ways, Article 28 care on an Article 30 platform. With Article 30 providers, how do we sort of crack that tough nut? And so on behalf of EMSC, we think it's high time to revisit, and that concludes my report. I'll turn the program back over to Dr. Doino for a brief discussion on this issue. Thank you.
Thank you, Dr. Cooper.
Of course, I'll entertain any questions that anyone else may have.
Anybody have any questions? A discussion on what Dr. Cooper mentioned. Do we have anybody who would be interested in forming a task force with Dr. Cooper to look at the issues? Okay. Dr. Winslow. Okay. So we have 1, 2, 3. Okay. So what I would suggest is after this meeting, why don't the 4 of you get together and then decide on how you're going to look at it, and can bring it back to the next CMAC meeting as to where we want to go with this. Okay. Excellent. All right. Quality metrics would be our next.
Great. Thank you so much, Dr. Doino. David Violante, the Chair of Quality Metrics. And we put a brief presentation together. As you know, our group had worked on a quality improvement manual that's been updated and out. It's onboardable. and we put a quick start guide together with that as well. And so we're very happy with where that's gone. We presented that to this group and to the SEMSCO for feedback. Most of the feedback we've received so far has been very positive. We're encouraged by that, and we'll be looking to move that forward at the SEMSCO meeting following this. As we're waiting for this to come up here, that was one of the first things that we had discussed. The second thing that we had talked about and provided some input on was a run chart and the ability to look at data. And the data that we had looked at was the use of blood glucometry in potential stroke patients pre-hospitally, and how every level of provider had done that over some time as a means to looking at ways to improve the quality of providing that measure. And so that was provided then, and we had asked everybody to be able to look at that measure at their own agencies and to work with the DI team to be able to see what their agency had done and whether they could follow the Quick Start Guide and manual and what that looked like. And some of the feedback from that has been very positive as well. For anybody that's interested, they can go out into the hallway here and check out what their own agencies look like in not only the image trend space, which is sort of the back of house piece of this, nuts and bolts side, but also the biospatial side of it too, which is what is going to look a little bit fancier, make it a lot easier, have all of these measures up, and providers, agencies, program agencies, and medical control physicians won't have to do all of the background work that's necessary in image trend. It'll auto-populate into biospatial. To that end, things that we're looking at in terms of measures are what's next. And so we're going to hopefully have those up here fairly soon. If not, we'll just provide a brief discussion about what those measures might look like. Things that we want to do are provide a core group of measures available to everybody around the state that we would like everybody to do, not as a requirement, but as something that they measure at the agency level to demonstrate quality that the state has approved, SEMAC and SEMSCO has approved as well. From there, going out to larger bundles, that would be a second level idea of measures that folks can do that are inclusive of those from EMSC, cardiac measures, stroke measures, STAC, et cetera. And then on from that, much larger group of measures that any agency can do on their own, should they want to. Since the data is out there, it's available, and it's something that we should all be able to use, especially since there are variances from agency to agency, region to region. And so that's where we stand with those. And so I'm going to turn this over to Dr. Red Leonard to talk about the measures that we're looking for at the state level. Dr. Red Leonard.
Thanks very much. Michael Redlener. I sit on SEMSCO and reporting also out with the Quality Metrics Committee. So to what David has stated, we can move forward in the slides if you don't mind. I think that the idea about creating a set of measures that are kind of viewed from the state lens and offered to agencies across the state as measures that are kind of verified as ones that are, one, evidence-based, two, clinically useful, and three, give another barometer of how we measure quality in EMS. The idea is to, that there are existing measures out there that we would adopt as part of this effort, so that agencies and program agencies could know where they might focus their energies in a productive way. So there's a range of measures from the National EMS Quality Alliance to there's a Florida project that looked to build measures within NEMSIS. They're all available and accessible through biospatial, and that's the group of predefined measures that we would like to look at as possibilities, as opportunities for the state to look to these already existing measures that we can apply very easily and use it with the quality improvement framework, right? Again, there may be priorities of the state, as David mentioned, that are several measures that the state would like to look at a specific time, and then there are about 20 measures that all exist within NEMSIS that we could use, agencies could use as a resource to help guide their quality programs. And again, and then in conversation with other organizations, making sure that the whole system of care is focused around things that are important to patients. And so that's the idea. You can go to the next slide. And again, these are familiar to a lot of people through different channels that you've worked with in many different areas related to stroke and STEMI, related to trauma, respiratory, pediatrics, et cetera. So there would be a menu of these measures that are options for any given agency. And again, like David said, I would refer you to the biospatial right outside the doors. There's an opportunity to see what that would look like. So yeah, I think that it's a great opportunity, and again, we would roll that into the work we've done around the quality improvement manual, and then kind of create a quality improvement framework for folks to look at these data and improve.
Next slide.
Next slide, please.
Here's a second set of measures that correspond to the first slide there of things that we're looking at as some of the core measures. Next slide. And so we'd like to turn over here next to Peter Brody, who's going to talk a little bit about biospatial, just to give you an idea of what it looks like, what to expect, how easy it is to use. I again want to thank the Quality Metrics team. They've done just a phenomenal job with all of this, and the data informatics team as well for being able to get the data out there, crunch the numbers and make it available in both image trend and moving to biospatial. Our end game with all of this is really for everybody to be able to log in and be able to see their agency's data, do run charts, and do quality improvement from this. So Peter, thank you.
Thank you, David. Peter Brody, Branch Chief Data and Informatics, Bureau of VMS and Trauma Systems. Biospatial, just for some of you may be a repetition, but just to qualify, as soon as data from every software vendor except for GMR is received at this New York State Elite site, it is shipped off to Biospatial, usually within 2 to 3 minutes, and its analytics are available 3 to 5 minutes after that. GMR has a separate contract with Biospatial where they send all of their data together. So that is why they're excluded from the transmissions to Biospatial. Biospatial provides a variety of analytics. We opted for this display and to make this brief yet informative. To focus on the quality measure we discussed at the last meeting of this body in December of 2022. This refers to the testing of blood glucose on a statewide basis over a 12-month rolling period for patients who are being evaluated for potentiality for stroke or a TIA. So in this particular graph, it is a 12-month period, and it is showing that 85% of the time the providers are evaluating the blood glucose on those patients. What this does not take into account is data that is not included on the chart, is that if there is an agency that does not have a CLIA license and would therefore not be able to complete that, however, the program agencies and the EMS agencies will have a better understanding of that for each individual agency when they're able to look. The data that you're looking at here is statewide. Scroll down, please. This shows that same information over that same 12-month rolling period, in where it stays at approximately the 85 to 90% throughout the course of that. This is a week-by-week representation, so there are 15 data points on there. You can make it so you have just the graphic line, or you can make it so it also has the numbers that are identified as the data values on each of the weeks, as Alex turns them on and off. And then scrolling down for the last one. This shows a different graphic representation. The top line is those that included the blood glucose testing on the stroke or TIA potential patient, and the bottom red line is showing the numbers who did not receive that. This is all based on statewide data. So there is no exclusions in them, except they are 911 intercept and mutual aid responses only. This does not include interfacility moves for a patient who may have gone to a local critical access hospital and then been transported to a stroke center, primary or comprehensive stroke center. But it does include patients who are dispatched from an urgent care center, as most of those dispatches are handled through 911. So just to further qualify that. Are there any questions on this? And we'll be developing these and working with the Quality Measures Committee to make sure that these are all available. The program agencies, we're going through some internal review process and making sure that we prepared information for the program agencies. And we hope to have that information completed and the process completed by the end of March, so that in May we're able to take some next steps. Are there any questions on what you have all seen? And I'd just like to conclude with that. It's been a pleasure working with David and Dr. Redlener and the remainder of the quality measures team. There's a lot of passion and interest in not only data, which excites me, but also combining the two together and using that data to make it actionable. So this is very exciting. There is a bit, if any of you had attended Vital Signs, Dr. Alex Mold sitting next to me, and Alex Blue, who's over at the FIPIC meeting. We're presenting at that and showing the two different sets of analytics that are available with both Tableau and Biospatial. And Alex Mold will be here for the rest of the day to do that. Thank you, Mr. Chairman.
Okay, thank you, Dr. Redliner and Dr. Belanti and Peter. Any comment from EMS Sustainability Committee? Okay. All right, moving on then. So old business. Ryan, if you want to discuss the state EMS Medical Director.
Sure. So that is progressing along. It's going through some processes on how it's going to, there's some back and forth going through the department on how it's exactly going to get put out there in position-wise and categories. So hopefully by the May meeting that will have some progress to it moving forward.
Excellent. Any discussion on matters? The presentation? Where?
Yep.
Okay.
Peter, can someone pull that up? The matters presentation. The matters presentation. It's a couple hundred slides, so it might take a little while to load. Mr. Chair, would you like to move to another item while they're working?
It's up. Okay, we'll wait.
Okay. I'll also thank Dr. Daly for adding some shadowing to the graphics on this presentation. Is that as good as we're going to get? All right, we'll roll with this for the sake of time. Thanks. So I'm Josh Lynch from Buffalo, New York, and I brought this up in about 2 minutes last meeting, and appreciate the opportunity to walk through, I believe, 6 slides today. So the Matters program is a resource that is available to any first responder agency in the state and has been for the last roughly month. You can go scroll down. So we built this program as kind of a collection of resources that all aim to help reduce the obstacles that patients need to get over to get to treatment. There are a few things here, and I'll direct you to the website, and I'll also throw some one-pagers and some cards up on the corner table here where Mr. Brody was sitting just a few minutes ago. You can go to the next one. So this program really was centered around the emergency department initially about 5 years ago when it started, and we quickly realized that there are other environments where patients with substance use disorder and mental health issues exist and need to be linked to treatment in an easy and efficient, and our approach is an electronic way without requiring any phone calls, waiting on hold, anything like that. So the referral environments are on the left of the slide, and as I mentioned, the emergency department is where it started. Referrals can also be made out of correctional facilities, inpatient units, through telemedicine, and also, of course, through first response agencies, primarily EMS and law enforcement across the state. You can go down to the next one. So here you'll see where the program is active. We have a little bit of work to do in the North Country. If anyone's from there and is interested in chatting, please let me know. But we refer out of about 100 hospitals across the state and many other organizations such as correctional facilities, either county jails or state prisons, drug courts, other entities. And we refer into a network of about 200 different treatment organizations that offer a variety of substance use disorder care, mental health care. We don't own any of these clinics. We don't have a financial interest in any of the clinics. We're really kind of exist in the middle space that helps facilitate the linkage. There is one other component that's a little less relevant here, but we also, through the course of a referral, if someone doesn't have insurance, we issue them a 2-week voucher to cover the cost of buprenorphine, or Suboxone is one of the formulations. If they don't have insurance, they get a voucher to cover the medication, and those vouchers can be redeemed at Walgreens, Wegmans, CVS, or Duane Reade, and a bunch of independent pharmacies across the state. That's a little bit more relevant to the emergency department side, where a patient might be getting a prescription. But that is a resource that's given for free to the patient through the course of any referral, whether it's coming from the hospital or someone's living room or the side of the road or the gas station bathroom. You can go to the next one. So really, there are 2 ways to make a referral, and I'll show you what that looks like, both of which really hinge on providers downloading the free Matters app from Google Play or the Apple Store. You can either refer a patient to telemedicine, or you can complete a Matters referral on the app, which takes about 3 minutes. If you are in the 8 counties of Western New York, sorry, the rest of the state, there is a third option that is a 24-hour hotline that are these business cards that I'll leave up on the corner of the counter. So if you're from one of the 8 counties of Western New York, you can take a stack of these, and all you have to do is just give it to the patient. So I know shuffling cards around ambulances and fly cars can be a challenge, so the app is really the primary base, but a real quick way to do it would be to just leave the card, and then the patient can make the phone call. It's a little less of a warm handoff as going through the app and actually making them an appointment, but in some cases that might be the best we can get. You can go to the next one. So when you open the app up, you can click I'm a first responder, and your options are listed on the second screenshot here, and really the options are request a telemedicine evaluation or refer a patient. And it's pretty self-explanatory. There will be some one-pager forms that are left up here also, and if you go to the next slide, I'll show you why that becomes important. If you click refer a patient, you have to type in an authentication code. This portion of the program is in partnership with the New York State Department of Health. The authentication code is on all of these one-pagers. Once you see it, it's the same for everybody. It's not a user account. It's just one other layer to get in, but it's on all of these cards and also on the boardable PDF document that is on there. So you can go to the next one. So if you type in Matters Network on either one of those, you'll get there. or you can snap the QR code on the bottom of the one-pager. Go to the next one, please. So there's a little demographic information that's collected on the patient, and then based on their address, they're shown a map with indicators of treatment organizations that we partner with. So it's not just for opioid use disorder, it's also inclusive of other substance use disorders and other hard to treat or hard to link diagnoses such as HIV and hepatitis. This is the way it looks today. In about 6 months, the platform will be a bit more nimble. And we're excited about that. So that will allow referrals for mental health as well. But the patient, you and the patient can see what services are offered at the location they pick. Then they just click select date. There are about 2,000 weekly appointment slots across the state, so tons of availability, lots of capacity, and that's, you know, really almost in every corner of the state. And click the next one. So all the information is sent behind the scenes. You don't have to make any phone calls, and really all this whole process is very fast. Go ahead. So we talked a little bit about the medication voucher. If someone needs transportation assistance, it's just a question, do you need transportation assistance? If they hit yes, they're issued instructions for an Uber voucher, a one round trip Uber voucher. If they hit no, they're not. We're working with other ride sharing partners to be able to make that transportation assistance piece a little bit more robust. We also have on the website or on the app the ability to send free fentanyl test strips to your organizations. I think the max is about 1,000 that you can request. It's free. You just go on the app, enter the information in, and we will mail them to you. There's no catch. You can go to the next one. So I just wanted to acknowledge, if you're thinking about unseen time, I spent a fair amount of time in the field and still try to, but thinking about approaching this patient population can be a challenge. It can be a challenge for the patient, can be a challenge for us as medical directors. It's certainly challenging for our crews that are out on the streets going to calls. And I think a lot of the root of those challenges really may be the fact that we don't have much to offer. So this quick 3-minute time investment on scene really can change the course of the relationship, could potentially change the likelihood that that you'll be back at that address tomorrow. It doesn't solve all the problems, but it certainly is a way to head in the right direction. So you can go to the next one. That's really it. Thanks for a few minutes. Sorry, it was 13 slides. Please accept my apologies. So the resource documents will be up there, and the business cards will be there too. Just so you know, there's 2 stacks, a stack of papers for Western New York and a stack of papers for everyone else. I'll throw my cards up there too if you have any questions or want to talk offline. Thank you very much.
Thank you. Anybody have any questions, comments?
What's been the use?
What? I'm sorry.
Like, what's the buy-in? How many people are using it on a weekly basis, or, you know, like, what do you see? And can you tell if it's EMS who's using it or facilitating that?
Yeah. So I don't have that specific data with me today, but we do have the ability to report back either to the EMS agency. We can get that granular to show what you were referring. There are several folks in the room that use this program in their respective hospitals, and you know, if they would like to know how many patients were referred in the last quarter, we can provide that information to them really easily. We can also show them where the referrals were sent to.
Thanks. And I guess the other question I would just have, as it tends to be a hot button issue, is you just spoke about it for mental health as well, going forward?
Correct. So the current version on the app, when the map comes up and you click on a marker to see where the treatment organization, what place it is, it also will show you what services are offered there. So for today, you'll see if it's offered mental health or not. In the new version that will roll out later this year, the experience will be you enter what type of problems the individual has, and then it shows you the resources that treat those problems. So you could potentially do a mental health only referral later this year. Now it's still driven around substance use disorder, but that programming is in the works to kind of roll out version 2 of this, which will be much more inclusive: mental health, hepatitis, HIV, and really all substance use disorders, including alcohol.
So I guess the question to that one on mental health is, do you think you'd be able to keep up with it? And I only say it from the point of view of we constantly hear the issues with access to mental health care and, and those things. And I guess how do you, anything.
So not surprising, we were asked that question a lot when we were venturing into doing this for opiate use disorder. And the relationships that we've made across the state as far as every organization kind of chips in a little bit of appointment availability. I think we've been successful in proving the concept now that we're up to 2,000 weekly appointment slots before we have even engaged for additional slots for mental health. So I would say the answer is we can confidently keep up.
I think that's awesome, and the work that you're doing, and thanks for presenting and giving some more insight. Even if you are more favorable to the western side, we look forward to the other side as well.
Yeah, thanks. I won't comment on the second part of it.
So actually, from the other side, so from the eastern side, I just to let you know, Josh and I actually presented together to the Sheriff's Association at their annual meeting. And I think we were both really favorably, really pleased at how welcoming the sheriffs were, how much they wanted to hear about other opportunities they could bring to the citizens of their counties. What we're seeing here is some of the sheriff's departments using this Matters Access when EMS hasn't even become a part of that patient care. Because the sheriff's deputies will be at the scene, they'll recognize that there are concerns with opioid use disorder, and a couple of the folks within any of these departments may end up becoming specialized in dealing with this population of individuals, and they're doing some real good there. The other thing that tied into that remains an EMS initiative as well is the Leave Behind Naloxone program, which I can't say enough about how much that's helping. So I think this is just all different pieces of a comprehensive approach to a really complicated problem.
Dr. Berkowitz?
Yeah, I just wanted to ask, other part of that problem is just getting BUP in the field and getting on the formulary. So I don't know if there's any update on where we are with that.
So, Dr. Daly, would you prefer to talk about this?
I have not gotten a recent update from the Bureau of Narcotics Enforcement. There is commentary on it in the governor's budget proposal, and I'm looking forward to my next conversations with BNE.
I will say that we have a protocol prepared for EMS agencies, and we have no less than 4 agencies that are literally ready to go today to provide buprenorphine in the EMS setting after overdose. And I also look forward to further discussions with the BNE so we can push this forward, take care of patients.
Excellent. Thank you for all your good work. Any other comments? Okay, moving along. EMS hospital wait times and diversions. As most of you probably know, there is a meeting at the plaza, which will be starting about 1:30, specifically with the health department to discuss the issue of EMS wait times and diversions. We are sending 2 representatives, Dr. Cushman, who's going over, and Mark Philippi, who will also be there. And I would assume anybody else that would like to leave this meeting and go there, you're certainly welcome to do so.
Can't be encouraging people to leave our meeting. That meeting's recorded. You can watch it later. Dr. Cushman, former chair Philippi, thank you for your help in relaying that information. There is a series of presenters at the FIPIC meeting on this topic. Deputy Commissioner Dr. Morley is also there and has been working with Dr. Heslin, the first Deputy Commissioner. Deputy Director DeZura will be presenting different data points from the Bureau side and information. So we're really excited about this, and thank you to Steve Kroll for bringing it up to have that discussion. Is really, I think, brought together 2 excellent councils. I think this is, one topic for them to discuss, but hopefully this opens the door for future conversations and future collaboration. I think especially as we see more and more collaboration happening in different topics and I think this is excellent. And so that is being recorded. It should be posted. I'm not sure how long it takes to get posted, but so for anyone who does want to watch, we will, when I find the link to that, we'll make sure to share it with all the members as well and let them, kind of see what's there. But Haney's is speaking, Greater New York is speaking, the Bureau is speaking. I believe Jeremy is representing ASAP. Mark Philippi is representing the State Council. So a number of different avenues looking at it from different directions. So we're excited to start the conversation and to see kind of where things go. This is, I believe today, if I remember correctly, is at like their equivalent of a systems committee. So, it's a committee at a committee level, and then the FIPIC will be brought up to the FIPIC meeting as a report out, similar to what happens here. So.
Excellent, thank you. Moving along, Suffolk County and Northwell, I'm happy to announce that that issue has been resolved, and I want to thank both parties for working together and resolving it. New business, Senate Bill S9407B, that's on the agenda. Who wants to comment on that? Okay, we'll move along since no one's going to comment on that. It was new business. I have no
Just
other.
for clarification, was that the body armor thing? Didn't we handle that already?
Yeah. Ryan, you can take a look and see. We'll take. No other announcements? Anybody have anything else they want to bring up before we end the meeting and give you guys back an extra half-hour time? All right, hang on 1 minute while we're looking up the Senate bill that was put up. It is body armor, so that's resolved. Okay, I have a motion to adjourn.
So moved.
Anybody second it?
Second.
Second. Anybody against? Okay. We'll see you guys in a few months.
Okay, I would like to call the February 2023 meeting of SEMSCO to order. If we could all stand for the Pledge of Allegiance and remain standing afterwards. I pledge allegiance to the flag of the United States of America, to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. I would like to have people observe a moment of silence for long-term member of SEMAC, contributor here to SEMSCO, Dr. John DeTraglia, who passed away recently, surgeon from Utica, responsible for developing the trauma program at St. Elizabeth's, and somebody who most of us recognize as an active member of SEMAC for the last few years and a long career of contributing to EMS in New York State. A moment of silence for Dr. DeTraglia. Thank you. Could we call the roll?
Allison Burke. Stephen Cady.
Steve Cady, present.
Dr. Krupe.
Bob Krupe, present.
Mark Devers.
Present.
Donald Duval.
Don Duval, present.
Michelle Fornes.
Michelle Fornes, present.
Carl Gandolfo.
Carl Gandolfo, present.
Gregory Gill.
Greg Gill, present.
Jason Haig.
Jason Haig, present.
Teresa Hamilton.
Teresa Hamilton, present.
Donald Hudson.
Donald Hudson, present.
Dr. Isaacs.
Doug Isaacs, present.
Al Kim.
Al Kim, present.
Steve Kroll.
Present.
Andrew Knoll.
Andrew Knoll, present.
Jared Cutson.
Jared Cutson, present.
Alan Lewis.
Al Lewis, present.
William Masterton.
William Masterton, present.
Mike McAvoy.
McAvoy's here.
Elizabeth McGowan.
Elizabeth McGowan, present.
Mark Philippi. Marianne Portoro. Dr. Raybridge.
Raybridge, present.
Dr. Redlener.
Redlener, present.
David Simmons.
David Simmons, present.
Carla Simpson.
Kyla Simpson, present.
Christopher Smith.
Christopher Smith, present.
Chad Smith.
Chad Smith, present.
Jeffrey Van Beveren.
Jeff Van Beveren here.
And David Violante.
Dave Violante, present.
We have quorum.
Thank you. Next item of business would be to accept a motion to approve the minutes of the December 7th, 2022 SEMSCO meeting.
Carl Gandolfo will make that motion.
Elizabeth McGowan will second it.
Any discussion, amendments, corrections? If not, all in favor signify by raising your hand. Any opposed? Abstentions? Carries. The only piece of correspondence I have is from a Senator George Borrello. I will later post that piece of correspondence on Boardable. It references one of the items that we'll discuss under the Systems Committee today, and so we'll postpone distributing it until after that hearing is held. For Chairman's report, there's a couple things on the agenda here. One is bylaws tag, which you see. The bylaws are, I have retrieved the draft that we have and am going to prepare a summary of what those changes that are proposed to the bylaws are. And I will post that on Boardable, but we also need to read it at the next 3 meetings so that people can agree with it or disagree with it. And so I'll prepare that for the next meeting and have that ready to go. I'll get it up on Boardable prior to that so that people can see it. I was going to ask Ann Smith to give a brief summary of the Rural EMS Task Force. She said that Ryan talks about it in his report, and so in the interest of time, we'll just let Ryan talk about it. Currently, at the same time as we are meeting, I got an invite from the folks at the Public Health and Health Planning Council, affectionately known as FIPIC, and they have asked us to please come and speak with their council about causes of long emergency department wait times, innovative models used nationwide that hospitals could take to reduce wait times, and what EMS agency responses have been to the issue. So in the interest of somebody who we know can deliver a powerful statement, I have sent the past chair, Mark Philippi, to represent us. He has about 6 pages of comments from many of you that he's going to present to them. He's allowed to talk for about 9 or 10 minutes and then present his written comments to them afterwards. Dr. Cushman is also there from SEMAC, and he's representing ACEP, and I think we have some other folks who are involved in both SEMAC and SEMSCO who will be commenting on that. So that's good. I think that's a good start to what we had talked about at our last meeting, to open the lines of communication with the folks from the hospital side of DOH. Also, just last item I want to mention is I have mostly put people onto committees where they want to be, talk to some people about structure of committees. Obviously, those need to be balanced so that 50% of the committee is SEMSCO members. You can have the other 50% or less be non-SEMSCO members. I'm playing around with that with some of the committees. If you see one that you want to be on or have a question about it, let me know. Our next project is to kind of match the committee list that we have to the boardable list because they're not exactly jiving with each other, so we're going to correct that. And then you're going to see 2 really amazing things today, I think. One is the quality metrics group is presenting their draft again, and the method, the quick start guide for quality that they have worked on for quite a long period of time. There's some very talented people here around the table who put that together. Hopefully we'll be able to approve that document today. That's a very long amount of work and arduous tasks that went into putting that together. You're also going to see the EMS Innovation Report, which you probably have read, on Boardable, and we'll have a brief presentation on that today. Again, that is a yeoman's job, which I believe left Ryan speechless, and really represents 25 solid, strong recommendations for improving our situation that we're in with EMS in New York State right now. So great work on the part of the groups that have been involved in that, and great work on the part of everyone sitting around this table who is taking their time to contribute to bettering EMS in New York State. So I appreciate everything that all of you do. It definitely matters. Next, first Vice Chair, you have anything to report?
No report, sir.
And how about second Vice Chair?
Thanks. I don't have a report, but I'm honored to be here and look forward to serving the body how, where, and when I can, so thank you.
Thank you. And next we'll go to the State EMS Director. You are no longer speechless.
Although some wish I was. So going to try and go fairly quickly here. I think many of you were here for the last meeting for SEMAC, so don't want to repeat too much on it. Operations, the big thing in operations, and actually in operations and education, is related to forms. So there is a new EMS forms page that is now live. So if you go to the Bureau website, on the left-hand side, it says EMS forms. It will have a drop-down menu. It will go into operations, education, Part 18s, almost anything. Some of the forms still need to be downloaded, so they're PDFs, but then they'll be, right below it will be a portal for them to be submitted. And so everything is right there. The most current documents are right there. As many of the documents as we could, we've turned completely into an electronic form in order to help facilitate just the process of collections and things of that nature, so that you wouldn't even have to download a PDF. It is, it's been up now for a little bit, for a couple of weeks. We haven't gotten too much feedback that there's something wrong or something missing, and so we're really excited about that. And so thank you to Jacob from the Bureau as well for working on all that and making that forms page come to fruition. And as new forms come up, as things change, it will all be updated directly in that page. So if you just know that page, know how to find things, you'll be able to find all the new things as well as things change and move forward. On the education front, a lot of really good things happening in education. Again, processing a lot of applications. I know education and training, I think, is going to give a report out on some numbers and certifications, some new programs that we're going to try. We also had an excellent meeting last night with the paramedic program directors related to the paramedic side of things and some great things going on there. They actually agreed to help us with an initiative related to field training. So one of the things that the state feels would be really helpful is to come together and have a standardized field training officer curriculum as well as a program. So we're going to look at that. They're going to look at that. I think we're going to bring that to training and ed as well to, once a framework is there at a concept is, what else we would like to see. And the paramedic programs, through their accreditation process, has to use a similar model. So they'll be working on that one. Thank you to Megan and her team for pulling that together and helping with that. Really appreciate it. Data and informatics. Peter has had his team outside here showing biospatial and a lot of different things that are coming with that, as well as what's coming from the amazing work being done from our Quality Assurance Committee and how those two bridge together so that people not only can have standards, but also know how to measure them, know how to see them, and to move them forward. So a lot of work in a really short period of time, and really appreciate that. Vital Signs will be October 17th to the 22nd in Syracuse this year. The call for presenters is currently open. So if you have a great lecture, if you know something good, if you know a really good speaker, please, by all means, we would love to have some great content there this year. And please go to Vital Signs Conference webpage, and you can submit your presentations there. The memorial will be in May at the Plaza. It will be the same memorial. We are still working on the new memorial. We are making progress, but it's just a slow process. Like everything else, unfortunately, supply chain is sometimes limited, apparently including in stone options. So we are making good progress, but it is a slow process. And so hopefully by next May, that will all be in place and be out on there. This year will still be on the same tree. There are 8 honorees who are going on, and we have the space for the 8 honorees as well on that tree. So that's positive. All the council dates are up and out, so that should all be posted on the webpage. I'm getting a nod from Val that they are.
Yeah, we also have flyers over on the table with the dates, and we also have the memorial flyer over there for anybody who wants to see who's being honored this year.
Terrific. So that is everything for this year. As we move probably through the summer, around August, we will determine what the next year's council dates will be. So we will try and always stay, in that 12-month period or stay ahead. I know that was a big request, especially with a lot of other things that are going on. I will also say that as you start to know things that are coming up, I know it sounds crazy to talk about 2024 already, but if you know your, NAEMSP conferences or things like that, please let us know so that we can try and avoid those conflicts. We are, trying to make sure that as we put those dates out there. The mental health program going really well, going out around the state. Really excited to have that one. One of the new initiatives that we will have with that one, it can be a live class, or you can take it recorded on Vital Signs Academy. And now we're going to do a live live online class that will be rolling out sometime in the next couple of months. And we're going to try that one for 1 or 2 months in like 2-hour blocks for those who want to be able to have access to that, but can't make it to a class at another time. The regulation packets, both for education and operations, have been completed. They've been through the first review process and the regulatory process within the Department of Health. This is really important. We suspect that they will go out for public comment between now and the next meeting. The public comment period may end before the next meeting, or it might be open during the next meeting. So this is really important. We will make sure that all the council members receive notice that it is out for public comment. We would encourage everybody to please make sure that you look at it, you read it, make your comments, make sure that everything's there, that you want to be in there. And if there's anything that you think needs to be changed or edited, there would be your time to make those comments. It's also important to feel free to write, "This looks good." So feel free to comment in the positive as well if you feel that everything looks good to you. That allows us to know that, it's gotten out into the public. If it is open for public comment during the next meeting, then we will discuss it at the council meeting on specifics. If it's not open for public comment during the next meeting, then we will most likely vote on it at the next meeting to approve it and then determine the effective date. My prediction is it will be open during the next meeting. We will talk about it. And then after that, if it has to go back out for public comment after any edits or things of that nature, that will happen over the summer. And then the final vote would be in the fall meeting. Rural Health Task Force, which apparently I'm talking about as per Ann, they had their first meeting yesterday. There was a list of all the Rural Health Task Force committee members presented, or I believe in the documents that should be up there. If anybody didn't get that or doesn't have access, please let us know. We're happy to share it. We're really excited to have that start yesterday. We had a great first meeting and just intros. Very diverse group of individuals, which is nice to see. Everything from the hospital world to the education front, to the SUNYs, to the volunteer, like really just an excellent representation, and we really think it will be some great product that will come out of it. Timing is pretty impressive, and I know Chief Benedati is going to be talking about this later, but the EMS sustainability paper, the white paper that was just completed, and the 25 recommendations that Chief McAvoy had mentioned before, really just align, as an amazing starting point for the Rural Health Task Force to not have to spend what Mike and his team of almost 50 people over the past year and a half have put together. So as they start on their pathway, they'll be able to have this amazing starting block. And so the synergy there, the timing of that being released today, with their meeting being the first time yesterday, really exciting on that one. Deputy Director DeZura is currently at FIPIC presenting on the data for EMS offload times at hospitals and the problems that we face during that. There's some incredible data that's been put together with that, some numbers on the number of minutes that we've spent just offloading patients. So please, you could like these meetings. Those meetings are also recorded, so you should be able to, I don't know how quick they get uploaded, but you should be able to go back and watch those, both Deputy Director DeZura as well as Chairman Philippi and Dr. Cushman and several other people will be there and presenting, so I think it's some really great content. I just want to go back and just give an extra shout out to the EMS sustainability paper. I've been here just almost 5 years now, crazy how time flies, and there's been a lot of really, really good progress that have happened, a lot of new initiatives, a lot of different things, but to see that the work that this committee has done, to see what they have put out, to put in a paper, to see what, how they've been able to summarize it in the beginning pages and then detail it, for those who want to or can go into reading, why they came to these conclusions, it really was just absolutely amazing. And so I just want to say thank you to all those members, both council members, non-council members. Mike was, finding resources around the state, literally at every turn. And if you really ever need someone to shepherd a team that is not always the easiest to keep focused and to keep going, Mike is your guy, because you would be on these WebExes and sometimes we would just go in another direction and be like, okay, we're going to come back this way and we're going to focus. So I'd like to give a round of applause for that entire committee and the work that they did. Thank you. Last item on our side, really excited for the budget. This is year 2 that we made it into the budget. We hope it gets through the finish line. There are some amazing opportunities for advancing EMS in the budget and the legislative changes, as well as financial components that come back as well in strengthening our system. So I know there's been a lot of conversations over the past couple of days. I look forward to, I think later in the meeting, we're going to go through a number of the things. I'm happy to answer any questions, both here at other times. And but just, really excited to see that advancement, excited to see that as you look in the budget, I think there's almost 15 items in the budget that, 15 items from the sustainability paper that get touched on or literally, like check a box from the sustainability paper. So to see that synergy, to see, the paper comes out and the ability to really move things forward, like almost immediately, when the budget passes, and to move EMS forward as an industry and as a profession to what everybody around this table represent, will be absolutely, amazing, and what a great way to start the year. So thank you so much. That's everything I have. Happy to take any comments, questions, or concerns.
Any questions for Director Greenberg? All right. One item I just piggyback on what he said. We do have the schedule for the entire year, and absent any hate mail, death threats, or pickets of the last 2 days, we'll keep the same schedule for committee meetings. So people who are trying to plan their travels up here to attend one of the subcommittees will hold on to the schedule for the rest of the year so people can figure out where and when they need to be. And I think that we probably have something that's as best as we're going to do. Doctors Marshall and Doynow, you want to talk about the SEMAC med standards?
From CMAC, we'll pass it on to Dr. Marshall to start off.
Thank you. Good afternoon, everybody. We have several motions to bring forward. I just want to state that this morning when we started medical standards, we actually started with 0 protocols to review, which is, I believe, the first time that's ever happened in the many years I've been here. So thank you all for all the hard work you've done. But we managed to find 4 motions for you anyway. So we're going to put them up. Protocol change. We'll do it the same way. So I'll start by talking about this one. So many meetings ago, we started talking about the process used to change protocols and implement protocols throughout the state, and somehow it had become disjointed. So there was a protocol change policy that was put into place several meetings ago, which was revised and made a lot simpler. And so that's what comes forward as a seconded motion from SEMAC to approve the protocol change policy.
So I don't think we need a roll call vote for this. So those who are in favor, raise your hands. Any opposed? Any abstentions? Looks like that carries.
Thank you.
It's been carried unanimously.
Okay. So the next motion that comes forward is a discussion that we've been having for a while now in terms of which set of BLS protocols is the official set of BLS protocols. And the changes that have been made to the collaborative protocols and the unified protocols from New York City, while they all include the BLS protocols that currently exist for the state, they have had some changes. So in order to mirror the BLS protocols that are incorporated within the collaborative protocols with the state BLS protocols, the motion was to accept the collaborative protocols as the BLS state protocols in excluding cities of 1 million or more.
So this comes forward as seconded motion. Is there any discussion? If not, all in favor signify by raising your hand. Any opposed? Same sign. Any abstentions? It passes unanimously. Good thing we have a parliamentarian here.
I know. The next motion that comes forward is the result of some discussion regarding medical device use in a pre-hospital setting and wanting to ensure that agency medical directors have input into which medical devices are being used by their crews and making sure that the medical director also has some approval in which medical devices are being used. So this was developed into a medical device advisory, and this was passed unanimously at SEMAC and comes forward as a seconded motion.
This was posted to SEMSCO and to SEMAC, so unless there's any discussion, I think we can vote on it. Any discussion? If not, everyone in favor, raise your hand. Any opposed, raise your hand. Any abstentions? Carries unanimously.
And one more motion, but the next one is a protocol change. The language to allow AEMTs to utilize supraglottic airways in unresponsive patients. So in the collaborative protocols on page 182, it reads alternative airway device in unresponsive adults. The word adults has been replaced with patients with an asterisk. And the reason for the asterisk is because at the bottom of that page under key points is the asterisk reads if equipped and trained. So AEMTs would be allowed to use supraglottic airway devices in unresponsive adults if equipped and trained. And that comes forward as a seconded motion.
Unresponsive patients.
Unresponsive patients, yeah.
Any discussion? Go ahead.
Is this a correction or a change? Do we now fall into that timeline that we just approved by the protocol change policy, or can we get this out sooner?
This can come out now, and it really was an oversight in the revision of the collaboratives.
So the only thing I would add to that is because this was made at Med Standards and moved up, it also still needs to go through the Commissioner's office. It's a protocol change. But, and just to clarify, the desire would be for an immediate change on that, correct?
Yes.
Thank you.
Any other discussion? This is a protocol change, so it does require a roll call vote.
Steve Cady,
Steve Cady, yes.
Dr. Krupe,
Bob Krupe, yes.
Mark Devers,
Yes.
Don Duval,
Yes.
Michelle Fornes,
Mickey Fornes, yes.
Carl Gandolfo,
Carl Gandolfo, yes.
Gregory Gill,
Gill, yes.
Jason Haig,
Jason Haig, yes.
Teresa Hamilton,
Yes.
Don Hudson,
Hudson, yes.
Dr. Isaacs,
Doug Isaacs, yes.
Al Kim,
Al Kim, yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Jared Cutson,
Jared Cutson, yes.
Alan Lewis,
Al Lewis, yes.
Mike McAvoy,
Mike McAvoy, yes.
Elizabeth McGowan,
Elizabeth McGowan, yes.
Dr. Raybrich,
Raybrich, yes.
Dr. Redlener,
Redlener, yes.
David Simmons,
David Simmons, yes.
Carla Simpson,
Carla Simpson, yes.
Christopher Smith,
Christopher Smith, yes.
Chad Smith,
Chad Smith, yes.
Jeffrey Van Beveren,
Jeff Van Beveren, yes.
and David Violante.
David Violante, yes.
Motion passes.
Question on the motion. Can I go home now?
Yes,
William
you may.
Masterson, yes.
That was a Freudian slip.
I was excited. I was getting packed up.
Okay.
Looks like the motion passes. You're on a roll there.
Okay. That's a good thing. See? Teamwork, teamwork. So just a couple of other items that were discussed at SEMAC. One is transport of newborn and neonates, and that, typically when we have a extramural birth and how we transport the mother and the neonate, in the bus to the hospital is not always the safest. And so we had a demonstration of some devices that are available for EMS to utilize in transporting newborns and neonates to the hospital. And they are available on the EMSC resources website page, so you would be able to find them there. They were actually demonstrated this morning, very simple to use and a lot safer than the way we currently transport neonates and newborns. We also talked about some data requests from a few meetings ago. So we asked for data on newborn to 3 years old in terms of whether or not weight was documented, medications used in these patients. And so for 2021, there were 18,259 transports identified, and out of those, 92% had weight documented by EMS providers. And I said that that was good, and I was told that that was fabulous. So it gets better. 12% of those had one medication documented, and the top 5 medications were oxygen, albuterol, Atrovent, midazolam, and Decadron. 2022, we saw a 38% increase in the number of pediatric patients up to age 3 to 25,154 transports. And out of those, weight was documented in an astounding 98%. So congratulations and thank you to all the pre-hospital providers for doing that, because it makes a huge difference when we're administering medication to these small patients. 14% had at least one medication documented, and it was all pretty much the same: oxygen, albuterol, Atrovent, midazolam, and albuterol ipratropium combination. The next thing I'd like to mention that we talked about was the medication assist protocol, which is actually the advisory is 0407, but there is a protocol, and myself and the department are going to look at that and bring back a recommendation to the May meeting as to what to do with policy 0407. We also talked about participation in the CARES program, which is a cardiac arrest registry to enhance survival. And Director Greenberg and the department is going to dust off a letter from the past that we sent to hospitals and providers and encourage everyone to really participate in the CARES program, because it will give us great data, and we'll be able to get statewide data as well as regional data, and hopefully make an improvement in our out-of-hospital cardiac arrest survival rates. And I think the last thing I want to mention is that we did have a long discussion, and I would recommend people look at the minutes from Med Standards. We had a long discussion on credentialing ALS providers and whether it's credentialing, decredentialing, ALS restrictions, and how that happens. And it was a really great discussion. It's certainly not over, but please take a look at the minutes from Med Standards, and I think that you'll be happy with that discussion. And that's my report. Dr. Doyle.
Okay, thank you, Dr. Marshall. We did have reports from Education Committee, EMSC Committee, Quality Metrics, gave an excellent report. And there was a presentation on matters, and I believe there's still handouts somewhere in the back on that. So if anybody wants that information. And that's basically our report.
Thank you. Any questions for Med Standards or SEMAC? If not, I will do an education and training report, call on myself. The Bureau gave a report of numbers for last year for students trained in our classes in New York State. We had 10,756 students and certified 892 CFRs in 58 separate classes, 8,972 EMTs in 573 different classes, 203 AEMTs in 29 different classes, and 689 paramedics in 64 different classes. That compares very favorably to statistics from the rest of the country. In fact, a little bit better than what we're seeing elsewhere. The Bureau also used a program called Tableau to do 10-year analyses of classes and people being trained in EMS courses in New York State, and determined that there really has not been a significant increase or decrease, that we have been training about the same number of people pretty consistently year after year for the last 10 years, with a slight increase over the last 2 years in paramedics who have been trained and graduated from programs. They also took a look at a few years of course sponsor activity and see no significant increases or decreases in course sponsors. A few of them have stopped running classes, but in general, same numbers of course sponsors running programs over the years. There are 2 new PSI sites. PSI is the testing vendor for the electronic exams. One is in Burlington, Vermont, and the other is in Erie, Pennsylvania. You may wonder why New York is testing out of state. Those 2 spots serve some rural areas in New York State where people have difficulty accessing testing centers. So those have been opened up to facilitate those folks better able to take the written exams at the end of their classes. A couple other things. The BLS practical skills exam work continues on piloting that. We're going to continue to work with Bureau staff through Boardable on the Training and Ed Committee with them on the book, the manual for that. There's another series of run-throughs that we're going to be doing at some of the downstate course sponsors. From that, we're gathering a couple of pieces of data, and I alluded to this at the last SEMSCO meeting. The first experience revealed that this is an incredibly different means of testing. We're going from just testing rote practical skills to asking people to critically think through scenarios. And that poses a huge change, not only for students in their testing, but for the examiners and for the faculty who are teaching the classes. That realization has caused us to push back the implementation of this from something we projected to do early this year to probably about another year and a half from now. And in the interim, we're also collecting data from these run-throughs on the budget impact that that'll have. And that will be consolidated with some other work that the Finance Committee and the Training and Ed Committee are going to work together on with the course sponsor surveys that they've done. And so we hope to get 2 groups from each of those together over the course of the next couple of months and recommend some adjustments in rates for reimbursement, as well as perhaps eligibility for reimbursement for people for courses around the state. So that's a work that's in progress. We had some new ideas of committees. One of them that we alluded to at our last meeting is whether our current requirements for instructor certification and recertification are actually as contemporary as they could be. So to that end, we formed a work group that's going to take a look at both of those, both instructor certification and recertification, and probably also consider reciprocity for instructors that are coming into New York State or people who are credentialed by other organizations like the fire folks, and what kind of reciprocity those folks would have to teach in EMS programs. The other thing that the Training and Ed was interested in is it really depends on who you talk to about their experience with PSI, the testing vendor. And, you know, there are lots of war stories of horrible things happening. So to get our handle on exactly what the incidence of issues are, the Bureau has provided us, and will continue to do so, with some data from what they call a Zen desk or a request system, where they put tickets in on issues that arise with the written exam testing company. Of the exams that are given, it seems that only about 2%, which is a small number, actually result in some sort of issue. The 2 primary issues that they identified are issues where scores aren't reaching from the PSI testing system into the Bureau's computer system. And so somebody who expects to have received a card didn't get a card because the scores weren't passed properly. And the second issue has to do with scheduling requests. And scheduling requests oftentimes are at the fault of the course sponsor, the student, somebody who didn't really understand the process for how they schedule their exam, not necessarily something that happens at PSI. So to that end, a couple things. The Bureau put up a new web page on their education site, which has answers to most of the ridiculous questions that course sponsors hear on a regular basis. And so somebody who is taking their exam and wants to figure out how they need to sign up, or they did sign up and they can't remember when they're supposed to take the test, or they signed up and they didn't show up, or they need help with rescheduling the exam, all that information is there, as well as an email address that a student could use to contact the Bureau to get help with a problem that occurs. So to that end, that will help with a lot of the issues that have occurred. And we're going to continue to get reports back from the Bureau. They're continuing to work with the issues that arise so that they get them resolved on a long-term basis and we don't see them. I don't think we'll ever get to the point where it's perfect, but it certainly is not at 2% of the total number of 10,000 some exams that are done a year. 2% is not a significant number to have issues with. So I think it's reassuring to the Training and Ed Committee of what's been happening with that. There was some discussion about regional training plans, and I mentioned to you, and many of you around the table know, that there are concerns about course sponsors, geographical lines, that sort of thing. We haven't figured out a genius way of resolving that issue, but it does appear on a couple of fronts, some regions, and in the future with a state system, to have a calendar of courses and to know, for all of us to know in real time when courses are being run, where they're being run, and facilitate the coordination of those a little bit more. And a lot of it is information exchange, and we're going to take a look at one region who actually has put some of that data together and share it amongst each other and see if there's a model there that others of us might use. The last thing that we had some discussion about was the funding for EMS training, particularly at the paramedic level. And it was noted that Excelsior funding, Excelsior College scholarships, can be used to fully fund tuition for paramedic training when that's a certified program or an associate's degree program. It was also noted that there are monies in each county under the New York State Jobs Funding Act that can be used for all levels of training, EMT up through paramedic. And to that end, we're going to work a little bit with the paramedic course sponsors who have put together a group independent of Training and Ed to try to summarize some of that information and use it in a fashion that we could disseminate it to people so they're more aware of what opportunities for funding are out there. And unless there's any questions, I think that's the end of the training and education
Question,
report.
Mr. Chairman?
Yes.
Thank you. Great report. Do we have a handle on what the needs are for EMTs and paramedics out in with all the agencies?
There is a need.
Oh, we know. What kind? There is no doubt, but can we move this process forward some way and identify locations or whatever to do more courses? We still can't fill ambulances with paramedics.
Right.
And you guys are doing a great job, but can we do better and get these ambulances filled with people?
I think if we latch on to some of the things that you'll hear in the EMS Innovation Report, that could solve or begin to solve some of those problems.
I've only read that 10 times. So.
I hear the 11th time is where you'll really sink in. I'll touch on that one a little bit. Yes, we have the opportunity to do some things. Steve, I know, is working on another workforce study, and I don't think we addressed that in it, but it might be something that we can look at from that point of view. The tough part is capturing, where's the missed opportunities in some senses. So in situations to where a person is looking to take a class but can't find it, or, it's not in their geographic area, or any of those components that come with it. And I think that's a challenging one. I'm happy to have a conversation, maybe you, me, and Steve offline, to see what we can do, see what we can try and capture from that side, in order to, kind of help know that. I do know, again, with the paramedic directors last night and speaking with them and talking about, where that is, and different ways to attract students, into going into those programs and so on and so forth, that, we're looking at it from many different angles, but then it becomes a question of how do you execute on that? So, because I think if I was to ask, every EMS agency around the room, do you have enough staff? They all would, raise their hand and say no, or not raise their hand, I guess, for that matter. So, how does that correlate to, because here's the other problem. Is it not that there's enough courses being offered, or is it not enough people who want to go take the courses? Because I'll tell you, and we see the numbers all the time, it's not that the courses are sold out. It's not that, they meet their cap. I think there was one paramedic program last night who I spoke with that said, we have a waiting list. So there's capacity, maybe not always in the exact place where people want to take it, but there's capacity. I can tell you from the state side, there's funding, and we're looking to do more and innovative ways to have more funding. So, that's a dynamic, and like I said, Chief Pandotti, I think will, touch on the rest.
I think we need to get creative to have a EMT paramedic training month or 2 weeks or something, and put all of our efforts in getting more people in the system. I know just moving along on what you're doing, it sounds like you're meeting the goals that you did last year. I think we need to more than exceed those goals to get people in our ambulances somehow. And I'm just asking to think about that, and is there a way we can?
Look, I'll tell you one thing that I think there's a missed opportunity. I have the opportunity to travel around the state. I get to hear a lot of different things, a lot of different ideas. Probably one of the biggest frustrations of the last year, and I think I mentioned it at the last meeting, is I get to meet with some incredible college students when I go and speak at some of the collegiate conferences. Sure. And at the last collegiate conference that I spoke at Binghamton, I was talking to someone, and I said, just out of curiosity, how many people did you have apply this year? And they said, oh, we were down. I said, oh, really? What are you down to? We only had 225 applicants. Wow. How many did you take? 15. Because they don't have the capacity. They know what their call volume is. They have a good training program. They know what it is. So, but what happened to the other 210? And they said, oh, well, we encourage them to apply again next year. Yeah. So there's a missed opportunity. And I will say that I think the local region and things like that, try to turn and say, well, you can go next door to, this fire department, this volunteer agency, this career agency. But I think just in the collegiate opportunity alone, we have a tremendous opportunity. And I think when we talk about, some of our academy-style classes, they're also the perfect population for, a summer program where they're not in school and may have some time off and be able to take an academy-style class and then be able to circle back and do it. And I'll tell you, that wasn't just one. It was Harpers Ferry, it was UAlbany, it was Syracuse University, all which have over the number of people applying than what they're able to actually take into their agency.
Is there any way we can help them?
I think there is.
There is?
Yeah, I think we need to focus on it, but I absolutely think there is. I don't think it will help the individual agencies. I think Harpers Ferry and them are doing great. They're sure. Role model for collegiate EMS organizations across the country. But I think there's opportunities there to figure out, well, those 200 other people who didn't make it in, how do we not lose you in the field? And I'll tell you, a lot of those students are pre-med, pre-nursing, pre-fill in the blank, which is what interests them in becoming an EMT and joining to get that exposure. And I think we've all recognized around the table, that's okay. It's okay to have this be a starting block of something, to figure out if you like healthcare, and then, to have a good solid 4 or 5 years, or maybe even more if someone's going to med school or things of that nature. I know Steve also has a program that happens on his that, takes it to the next level for the collegiate side. So I think there is a missed opportunity that we can.
I'd like to preface my comment with this is not me volunteering to lead this initiative, but I do think that we have something that's coming up that sort of falls in space between where our committees are. And we used to have a committee called PEER, Public Affairs Committee, and we did away with the committee because it really didn't have a mission in any projects. But there's a provision in the state budget where the governor's office has recognized promotion of EMS as a career is important. The Bureau has done things to promote EMS as careers. At the program agency meeting, it was talked about the program agencies are doing some things, but the point Mr. Lewis brings up is great. We are producing roughly the same number of people at a time when we have acknowledged we're 10,000 short, 20,000 short, whatever the number is. We know that our numbers of, we didn't, if you went through, you went through with us, Ryan, a meeting or two ago, the number of people that are certified and the number of the people that are working. And that is, we know that is down, so maintaining isn't enough. So perhaps it's a role that can be filled here, whether it be a technical advisory group, whether it be a rejiggering that committee. We have the talented people around the room. There's work from Mr. Bonatti's report. We could put together a EMS plan for recruiting and retention. Seems to me that's what, if we have classes that aren't full and we're asking for more training money because we want more classes, that's got to be accompanied by how do we get people in there. It seems to me this is the group of people that have the talent to do that, or the people that are joining us in the audience that aren't members but are EMS agency leaders in their regions. And I do agree with Ryan on the colleges. If you're, I'm at an agency that's 10 miles from a major university. They turn away hundreds of kids, and I have a couple dozen volunteers that are college students. But that only works if you're near a college campus. Obviously, it's not a statewide solution.
And just a final comment, I think we need to put our thinking caps on and accelerate this program to find people and to train them more quickly to get them into our system. We're never going to catch up if we don't make something like that happen. And you're doing a good job. I'm not criticizing what you're doing, but I think we need to, before COVID, 8-10 years before COVID, I said when Lee Burns was director, EMS is in crisis. And it started to decline. And then COVID fractured us. We are in such a need for people. I think we have to do something different until we get back to where we're at a flow where EMS has all of the people it needs, and we're not parking ambulances because we can't put people in them. So I just ask you to think about that. Thank you.
One more comment, Mr. Masterson?
I think all is open now. We ran the boot camp, the grant program that was very successful, was paid for up front. Kudos on that. What I'm running into is there's no connection between education and recruitment and retention. So I have providers coming into my course that the state is going to reimburse for because they're a member of an agency. I have other people coming into the course that pay for it. When they're done with the course, there's no incentive for them to join an ambulance company or a fire department, paid or volunteer. So I've talked about this before. I know it's hard, but we need to have a program that says if you complete an EMT class and you join an agency, paid or volunteer, and you maintain there, that agency should be able to voucher and receive reimbursement for that, volunteer fire department, ambulance company, hospital-based, whatever. There is mechanisms, but they got to get an account, and I think we got to make it a program. So if you join a fire department or an ambulance, and you maintain whatever the rules are of the fire department or ambulance or a hospital, that they can voucher the state at some point, 6 months later, for reimbursement. And then give that to the, however the mechanism is. I have everybody that says you can't do it, but we have a lot of volunteer fire departments and ambulance companies who are primary 911 agencies who, take people, fast track them to get them on board so that they can come into the class, without having to lay out any cost, because we don't charge them, and a lot of course sponsors do that. The college kids is great. In my region, we run 6 summer EMT classes, all with about 40 in them. So they do appear. They actually appeared up at Steve's area. We posted on our website. recruitment and retention for his area, but they don't appear long-term. We all know that. They take an EMC class to go on to another career or another box that's needed. Where we do have citizens who want to get into EMS, and, saying it's very hard for them. We're a hodgepodge. So I think that recruitment and retention, where there's some mechanism for an agency, any EMS agency, to voucher for an EMT that took a class, that's one little step I think that would tremendously help out recruitment and retention. But the other stuff doesn't end. College programs are still having difficult times. Paramedic programs are, so we've got a lot of stuff to do, but that's one example I think we should push through.
Were you thinking you may chair a group to do that, sir?
I should have started like Steve. I will
believe you can go
assist.
back.
I will assist in that, but yes, I've been waiting because I have Nutsvera, FASNY, Onion, all the associations in my group, and they're all complaining of the same thing. They're all paying for, learn as you earn programs. They're all paying, but the big easy one is I can have somebody join a department, not pay anything, take an EMT class, and that's what a lot of them are doing now. And then they leave as soon as they get their EMT to go on to nursing. I think I want to do the reverse end, where they stay within that agency and contribute, then the agency can voucher, or even the student can vouch. Either way, you know what I'm saying? And, I get paid up front. They get paid later on. I can't have somebody give them time and their money. They won't do both.
Agencies can voucher, students can't. So I'm just giving a framework for that. I think you can get there, just it can't be, the student can't voucher is not a pathway for that on our side, but the agency, if it wasn't a core sponsor, the agency could, if they're a participant.
The problem is I have 110 agencies to educate them, to set up accounts so they can voucher. They're not going to do it. You know what I'm saying? They're busy putting ambulances out and other things. So it has to be a program that's easy for them to apply to, you know what I'm saying? And that they can do. I can't, say in a system in that. I tried with an agency and they got frustrated. The chief, he did not want to do the paperwork and, this is you know what I'm saying? So they just move on.
Yeah, the earn to learn kind of programs are very successful, and you're right. Some of the ways you have to create workarounds and agreements with various teaching institutions from the agency, so that, for instance, we would pay for prospective students, tuition to the school, and the school would voucher, and we'd have an agreement legal in place. And once they complete the program, they would reimburse us. But we would lay out the funding for it so that they're whole and the students have a slot. I'm hearing there is a way for agencies to voucher. We've done that as well. It's just the whole process is a little cumbersome. So a streamlining of it, I guess, could be an improvement.
And Mike Masterson is on the group that's working with the Finance Committee to address that, some of those issues. So we'll carry it into that work group. Mr. Kroll, you want to talk about finance since we're on that topic already?
Yeah, thank you. Good afternoon, everybody. The Finance Committee doesn't have any motions to bring forward, but I do have a report on some of the things that we are working on. The biggest focus of this meeting is preparing for the 2024-2025 budget submission. The budget that's currently under consideration is the 2023-24 budget in the state capitol, but preparation for the state budget begins many, many months in advance. So by the time we convene for our summer meeting, the staff and the Division of Budget will already be working on the budget that will take effect 1 year from this April. The director has asked us to accelerate our pace because we tend to be submitting our material late, and we want to get in early. So the area in which we make recommendations are funding for the program agencies and funding for education. This meeting, we focused on funding for program agencies. We met with the program agencies Monday afternoon as part of their meeting, and then we convened again here yesterday morning. Essentially, we asked the program agencies to explain to us the types of things that they do that are important for community, are important for EMS, but they are doing without receiving additional reimbursement. The program agencies have not received an increase in reimbursement since before the year 2000, so more than 20 years, yet they've picked up many, many new things that they do. And so it is a given that they should receive inflationary updates, and they have not over many years. It's a given that the types of tasks that they work on are becoming much more sophisticated, and we need to hire really qualified people that have experience. And so the jobs have become more complicated, and it's a given that they can't afford to pay for the salaries of the people they need. So I'll say to my program agency colleagues around the room, you do amazing work, and yesterday, from the Finance Committee perspective, we got a really good look at just some of the things you do that are so very important. And so they gave us recommendations on things that we could work into our recommendations for next year's budget. And I'll take 1 minute to mention some of them. The first thing that came up was EMS recruitment and retention. The program agencies are out there trying to recruit people into careers in EMS. Facilitating and adopting the management of EPCR systems. The quality and data work that happens at the regions. And it was remarked, I remember when at the regional office you would have a highlighter and you'd be going through the stack of PCRs this thick, and you had a circle if the date of birth wasn't there, and you had a circle if the X wasn't there. That wasn't real QI. That was just you didn't have to be a specialist. Now we're using data-driven informatics to come up with quality metrics. And those quality metrics, we're going out and educating providers to get better. So I know in my region, we've done studies on whether or not, what percent, it goes back to some of the things that were talked about by David at the SEMAC meeting. In what percentage of cases for a suspected stroke did we forget to do the blood glucose, right? And then we go out and we do education. Interestingly, the program agencies have become a hub where the public comes. And when I say the public policymakers, representatives of the hospital field, the media, for information about EMS. Not because they're out there waving their flag, but because we all send people to the program agency. Someone calls up the EMS agency and says, want to talk about this. They go, you should talk to the program agency. The program agency has become a hub of expertise. They serve as our representative to things like hospital programs on trauma, on stroke, on burns. So in a way, they're an ambassador to the whole healthcare system. And so those are just a few of the things that we talked about that they do. And we're going to take all of that and work that into the narrative for next year's budget request so that we can demonstrate to the Department of Health the Department of Health can use that to demonstrate to the Department of Budget that the program agency's work has gone from a certain amount in 1997 to much, much more in 2022. In addition, some of the program agency leaders are searching for a document that was done in 2017 by one of the program agency heads that actually compared the deliverables from 1997 to 2017. We're going to find that document and we can incorporate that into this. So that's really the first part of what we did. The second part of what, and Steve Cady volunteered to do a little bit of a survey of the program agency so we can get the quantities. I talked about these things in an anecdotal way. He's going to try and get the quantities of work they're doing. The next thing that we're going to work on is the education budget, and that's where this interfaces with the conversation we just had. How do we spend all the money to maximize the number of people that take EMS courses? We did some work on that for this year's budget. As Ryan pointed out, though, we have not yet been able to, we haven't spent all the money we have to spend. And that's frankly a problem for us. We have to figure out how to, it's hard to ask for millions more dollars when you're leaving money on the table. And so we are going to have to help the Bureau plan for the following year. And I use this as an example. You know that when you are scheduling surgeries in a hospital, that one of the surgeries probably going through an OR each day is going to get canceled. So they usually book one extra surgery, figuring someone's going to get canceled because they don't want that OR to be empty for that hour or 2 hours. So they might book 8 in a spot of 7. We have to figure out how we can commit ourselves to a way that uses all the money without running out and without going over. So that'll be our project going forward. The last thing to mention is a project that's jointly going on between training and education and finance, and that is the EMS cost survey. Steve Deser is not here. We're watching him live. Some of us probably are watching him testify live on on the internet over at the PFIPIC. But Steve helped us design a survey. Actually, Mike McAvoy was the architect of this many years ago. He did a survey on this as well. And that's how much does it cost for us to do EMT training? We're going to get the data's in. We're going to get the training and ed and finance committee members together and work on a analysis of this so we can go back to the Bureau and say, here's evidence that it cost X to put on an EMT class when it's being reimbursed at Y. Again, that's a number that hasn't changed in many years. That's $700. If you calculate the CPI over those years, it's quite a big gap. We're going to try and put some more numbers to that, so that's something that the Bureau can use in increasing reimbursement, and then, of course, going back to get more money to do that. So that's what's happening at the Finance Committee, and I'd be glad to answer any questions.
Any questions for Steve?
No question, but yeah, we went from training education very quickly to finance. So I can understand why that would happen. You're very closely related. But I did want to ask a question about DOH, whether or not they could speed up the approval for new training centers. For example, NYU applied for a funded EMT training program that would evolve into a paramedic training program. So I'm just wondering about that whole approval process, if there's some way to speed it up.
Absolutely happy to take a look at it. I mean, there's certain things in the process that just take time, especially in regards to, putting things out, comment periods coming back. We are looking at, what that approval process looks like in the future. And then the big thing is, and again, sorry to go back to it constantly, but, in the budget, there are some things that would, really improve what that process is and would speed up that process, as well as set geographic locations and things like that to core sponsors, which I know is a concerning topic for many.
Mr. Devers, you want to do the systems report?
Good afternoon. I guess we'll get the exciting stuff out of the way first. So we do have a seconded motion on a CON appeal. So the seconded motion that comes before this full council is to reverse the decision of the Southwestern REMSCO in the Chautauqua County EMS denial of transfer of the municipal CON to a permanent certificate of need. Do we have any discussion? And this is a reminder, this is a non-de novo proceeding, so we cannot enter any new information into it.
I'm sorry, can you say that in the mic so it's on the record?
At the last meeting, you did something very helpful, was you explained exactly what you're voting for when you vote yes and what you're doing when you vote no, because all the double negatives and stuff, that would be helpful.
So the vote from the REMSCO was to deny the permanent conversion. Because in the law, we cannot reverse, we can only amend, modify, or reverse. We cannot uphold a REMSCO's decision. In this case, if you were to vote no on the decision to reverse, you are voting down the REMSCO's decision, so you are incorrect. Did I get it mixed up?
No upholds the REMSCO denial.
Yes. No.
And yes reverses the REMSCO denial and issues the CON.
Yes. Yes means no, no means yes.
Is there a discussion?
Yeah, Mike, I am the representative from the Southwestern region, and I was involved in the original vote for this application on the CON. And I would like to just put before this group if that might represent a conflict of interest today in the vote, whether to vote or whether to abstain. I would ask the group.
If you don't make any money out of it, there's no conflict of interest. Yes.
Any other discussion?
Yes, Steve Cady. I'll try to make this as quickly as I can, but however, the municipal CON process is very close to me. So I'm going to have to do speed talk as in the narrator of a commercial that gives the side effects of drugs. So I'll try to make this as fast as I can. Yesterday, the question was asked, is this appeal before us issue a procedural, timeline, or need? With that said, procedural is outlined in 06060901. Just a reminder, it has been discussed many times at this level that this is a policy statement and not a regulation and not a law. Next, the timeline is outlined on policy 0901 for the municipality CON, or for the Muni CON. And on page 3 of that document, it does state the failure to initiate EMS operations in a timely manner within 60 days of notification to SEMSCO may contraindicate the declaration of need and may work against the municipality's ability to transition to a permanent operating certificate for that 2-year period. It is important the word may, it does not say shall or will. And we all know that may, in better terms, is a soft term where shall and will is a hard term. It is noted in several places in the appeal documents that 59 calls answered in the 2 years of the Muni CON. However, the only note for why this number is so low is in the hearing officer's report on paragraph 31, which the hearing officer notes the time of the ambulance placed in service was late 2019, and the hearing officer also notes the hearing officer used the explanation, which is in quotes for him, governmental red tape. So it appears to me procedure and timeline fall under policy and not law and regulation. Now let's get to the point of need. In reference to the Muni CON, it is noted, obviously we have all, hopefully, have read Chapter 45, Article 30, Section 3008, Paragraph 7A, which does indicate that Muni CONs, all requirements on determination of public need for establishment of the additional emergency medical service. So that pretty much outlines that the county was issued a Muni CON by the Department of Health. So it interprets to me that the county did establish a need to the Department of Health under the Muni CON. In the hearing officer's discussion and conclusions, documents are several times referenced, noting strong presumption. I'll try to do this as fast as I can. Paragraph 23, the case of Utica versus Daines, highlighted to the use of the word strong presumption is powerful, substantial, and significant. Paragraph 22, it's noted that strong presumption is in favor to approve the applicant. Paragraph 25, it is noted that strong presumption is in policy statement 0901. In paragraph 27, the hearing officer does discuss the distinct advantage the municipality has in the CO1 process, but does not offer an opinion on whether that is right or wrong for that advantage. Paragraph 28 does highlight the SOD that was issued by the Department of Health. However, the hearing officer does not offer an opinion of his effects of that COD on the application. Paragraph 29, 59 calls in 2-year time frame, which I just discussed a little bit earlier. Paragraph 35 notes that the southern part of the county has been served by the applicant. Paragraph 37 notes that the public hearing compelling testimony was heard from several individuals describing the need for the EMS assistance in the county. Paragraph 39, public hearing testimony of the applicant's existing ALSFR, and it is growth since the beginning of the ALSFR program. Paragraph 40 notes that 52 letters of support were documented. Please note that one of those letters are from the county executive supporting this CON approval. Paragraphs 42 and 43 do note 2 opposition letters from outside of the county and 1 from inside the county. However, when I went through the opposition letters, I found 2 letters from volunteer fire departments, 2 ambulance services, and 1 town official in opposition. So that would be 4. Paragraph 44, the hearing officer states, and I quote, ultimately, this is a difficult decision to make. Paragraph 45, the hearing officer does note that the applicant did not take advantage of its opportunity to show need. Also, he notes that does not mean that a need does not exist, and further notes that does not automatically defeat the strong presumption afforded by the public health law. Paragraph 49, the community itself would benefit from granting the application. Paragraph 50, once again, notes the difficulty in making this decision. With that all said, the hearing officer recommendation was to support the application and recommended to grant the CON. The regional council's CON committee voted in favor of the CON and pushed the motion to the full council with a vote of 4 ayes, 1 nay, 1 abstention, no absence. According to the administrative law judge record and documentation, regional council voted on the motion for the CON committee to grant the CON with 11 in favor, 6 against, 5 abstentions, 9 absent. He noted that there was a quorum and also noted a vote of 16 in favor was needed to pass, so the motion to grant the CON was not approved. The ALJ did note in his statement, he talked about the SOD from the Department of Health. He noted the strong presumption. He also noted the 59 calls in 2 years. The ALJ's conclusion and recommendation was as follows, and I quote, based on the record, the applicant failed to meet its burden of showing that the SEMSCO erred in denying its request to convert its Muni CON to the permanent CON. The SEMSCO's decision should be sustained. With all that said, I feel the ALJ handled this appeal as a standard CON and not a municipal CON. And he failed to take into consideration the hearing officer's report, the vote of the CON committee, and the distinct advantage that the municipality has with Public Health Law 3008 on strong presumption and the case of Utica versus Danes that gives that municipality that distinct advantage. I support the county getting their CON, and I will vote yes to reverse the Southwestern SEMSCO decision not to issue the permanent CON. Thank you.
Should there be a round of applause?
And I apologize, I could not speak any faster.
Any other discussion? If not, this would be a roll call vote. We can begin the voting. Okay. So
No upholds the SEMSCO denial of the CON. Yes reverses the SEMSCO denial and issues the CON.
Steve Cady,
Steve Cady, yes.
Dr. Krupe,
Dr. Kruby, yes.
Mark Devers,
Mark Devers, yes.
Don Duval,
Don Duval, no.
Mickey Fornes,
Mickey Fornes, no.
Carl Gandolfo,
Carl Gandolfo, yes.
Gregory Gill,
Gill, yes.
Jason Haig,
Jason Haig, yes.
Teresa Hamilton,
Teresa Hamilton, yes.
Don Hudson,
Donald Hudson, yes.
Dr. Isaacs,
Doug Isaacs, yes.
Al Kim,
Al Kim, yes.
Steve Kroll,
Steve Kroll, yes.
Andrew Knoll,
Andrew Knoll, yes.
Jared Cutson,
Jared Cutson, yes.
Al Lewis,
Al Lewis is a no.
William Masterton,
William Michael Bassett, yes.
Mike McAvoy,
Mike McAvoy, yes.
Elizabeth McGowan,
Elizabeth McGowan, no.
Dr. Raybridge,
Raybridge, yes.
Dr. Redlener,
Michael Redlener, yes.
David Simmons,
David Simmons, yes.
Carla Simpson,
Carla Simpson, yes.
Christopher Smith,
Christopher Smith, yes.
Chad Smith,
Chad Smith, no.
Jeffrey Van Beveren,
Jeff Van Beveren, yes.
and David Violante.
David Violante, yes.
We have 23, 22 yes, and 5 no. So I believe you need majority, which would be, there's 32, so majority, 30, right, half of 32, so 17. So it's not, how do we say it? So the motion passes.
17
Yes.
yes.
No, the motion. Yes. if you
So the
voted
motion
yes,
passes.
The motion
yes,
passes.
The motion passes.
Yeah.
Okay, there we go. So yes, the motion passes.
Motion passes. To reverse the decision and issue the CON.
Permanent CON.
Okay, now you got that out of the way. The rest of systems can begin.
Quick report, the physician fly car that we were working on, according to Mr. DeJura, there is no actual way for the state to grant operating authority for any service without going through a CON process. So I guess I will leave it up to Ryan to figure out how to deal with the hospitals that already have programs in place. We do have a group that was working, it's kind of on pause right now, on 0606. There is a draft document of that. I believe I put it in Boardable the other night, and hopefully I put it in the right spot of Boardable, because that sometimes outsmarts me. And finally, I will turn it over to Chief Beninati for the actual exciting part of the Systems Committee meeting.
To the moment, are there any questions for Mr. Devers about systems? All right, Chief?
Thank you. And we didn't agree to brief before we started, Mr. Chairman. He's busy. As I said, we did not agree to brief. You had mentioned that I would be providing a brief report. I don't know that it's going to be that brief.
It could be long. Are you going to read every page?
No, sir.
All right.
Here till 4 o'clock. Mr. Devers, Chairman McAvoy, Director Greenberg, Acting Director McDonald, members of the State Emergency Medical Services Council, elected officials, and fellow EMS colleagues. Good afternoon. Director Greenberg had made the trip from Albany to be on hand for the Dutchess County EMS Council's annual awards dinner. What a surprise and honor it was for the award recipients to have the New York State EMS Director present to congratulate them on their award. It will be an evening they will not forget. A beautiful fall evening outside Roosevelt Fire Station 3 in Dutchess County, a group of a dozen or so EMS practitioners, EMS leaders and educators, hospital EMS coordinators, and fire chiefs assembled following the awards dinner. It was Wednesday, September 22nd, 2021. Dutchess County, like other counties across the state, was facing EMS system challenges. It was becoming increasingly difficult to find available advanced life support agencies to respond to and provide ALS assistance when necessary. EMS resources were becoming thin across the county, and mutual aid was being overutilized for agencies' inability to cover their own response area. During the next several hours, Director Greenberg had the opportunity to discuss with the group the challenges that we were facing in Dutchess County. He was able to hear from the experienced and inexperienced. He asked tough questions and received answers he didn't always want to hear. Today, we all know the topics discussed, which are no different than any other geographical part of the state. The topics included staffing, pay and pay disparities, benefits, working at multiple agencies just to earn a living, access to EMS education, the ability of commercial agencies to meet the public demand without access to public funding, increased response times, the need for municipalities to fund EMS, integrity of the profession, hospital overcrowding, inadequate insurance reimbursement, and the discussion of the role of the Bureau of EMS. The conversations were enlightening, educational, and engaging. After several hours of conversation, the night needed to come to an end. With it being a weeknight, we all needed to travel home. I recall asking Director Greenberg what the Bureau is going to do to address all of these concerns. Without hesitation, the Director turned to me and replied, "You are going to come to Albany next month to the SEMSCO meeting where you will present a report on our discussions this evening." Late at night, we parted ways with a great deal of provocative thought. After that evening, the Director and I only spoke once more before the EMS Memorial on September 30th of 2021. The Director mentioned that at the EMS Memorial, we would hold a brief meeting with Chairman Philippi to discuss me presenting at the SEMSCO meeting the following month. Hours after the EMS Memorial concluded, that meeting occurred. It was agreed that I would make a presentation to a joint session of the Systems and Innovation Committees. Over the next few weeks, I developed my presentation, EMS in Crisis, a New York State perspective. On October 20th, 2021, before the joint committees, I made my presentation. In summary, I said, "Today I am here to say what many before me, including New York State Emergency Medical Services Council Chairman Mark Philippi, said at the last SEMSCO meeting. EMS in New York State is in crisis. Over the last several years, we have seen the deterioration of the EMS system across the state. Today, many geographical areas in New York are without adequate EMS coverage. Days do not go by without EMS calls being passed from agency to agency in a desperate attempt to find an agency to respond. Often, the patient is waiting an excessive amount of time to get an ambulance. Every day, we see new headlines across the state and the nation on topics affecting EMS coverage.
Topics include staffing shortages, the decline of volunteerism, stagnant reimbursement, hospital overcrowding, inadequate coverage, the use of mutual aid, pay disparities, absence of consistency in the EMS model, and the lack of EMS educational opportunities. Yet, we have not developed a comprehensive approach to addressing our crumbling EMS system. In closing that day, I said, I want to thank you all for listening. I don't have the answers. What I do have is the desire to see emergency medical services in New York State receive the recognition, funding, and structure necessary to meet public need and lead us into the future. As I concluded my presentation, I was relieved when those attending applauded. The applause was followed by comments of support, which led to Chairman Philippi asking if I would serve as chair of an EMS sustainability tag, and I accepted. Several attendees approached me after the meeting and congratulated me on my report and volunteered to be on the tag. It was the right message at the right time. Not being a state council or Albany insider, the next several weeks were spent learning the administrative process, understanding organizational structure, and developing the formation of the technical advisory group. To have an effective industry-respected tag, we needed EMS professionals representing all EMS disciplines in the state, and we did just that. Additionally, we incorporated our partners from the Bureau of Emergency Medical Services, EMS education institutions, regional offices and program agencies, hospitals, the fire service, Department of Homeland Security and Emergency Services, Emergency Communication 911 centers, United New York Ambulance Network, New York State Volunteer Ambulance and Rescue Association, and New York State EMS coordinators. I feel compelled to thank the members of the EMS Sustainability Tag and those who supported our mission by reading their names and their leadership role. Teresa Allen, Ryan Alo, Co-Chair Education, Shivam Barrett, Co-Chair Education, Patty Bashaw, Michael Beninati, Chair, EMS Sustainability Tag, Alan Bell, Brian Bronner, Jeffrey Call, Dan Clayton, Mark Devers, Chair, Government and Public, Amy Eisenhower, Paul Glasser, Stephen Gordon, Co-Chair, Identifying the Problem, Ryan Greenberg, Jason Haig, Chair, Operations, Teresa Hamilton, Curtis Hammond, Timothy Hardy, William Hughes, George June, Benjamin Keller, Bill Kennedy, Stephen Kroll, Sub-Chair, Staffing, Dr. Langsam, James Lee, Al Lewis Sr., Vice Chair, EMS Sustainability Tag, Robert McCartan, Sarah McCartan, Co-Chair, Education, Dr. McAvoy, Editor, Keith Monshine, Sarah Moore Groover, Jim O'Connor, Valerie Osga, Joseph Pataki, Mark Philippi, Brett Roberts, Douglas Sandbrook, Chair, Hospital, Raymond Sarawick, Co-Chair, Identifying the Problem, Christopher Smith, Susie Sermonat, Bryce Taylor, David Violante, Chair, Agency, Wendy Walker, Jonathan Washko, Co-Chair, Staffing, and Brian Weedman. On November 10th, 2021, we held our first TAG meeting and agreed on our mission statement. From there, we went on to form subgroups, agency, education, government support and public, hospital, identifying the problem, operations, and staffing. Members stepped up to participate in subgroups of their interest. Members stepped up to serve as chair. Each subgroup was presented with a number of topics and questions to address, in addition to developing their own related topics. The collaboration and relationships that this process has created has been nothing short of remarkable. Subgroups discussed and debated a variety of topics, ultimately establishing consensus. Subgroups met opposite of our bi-weekly TAG meetings. TAG meetings were used to discuss shared and overlapping topics, receive reports from the subgroups, and set direction for the future of the project. Today, we will present the State Council with our completed paper. This paper is a collaborative effort. The white paper is the result of numerous hours spent in meetings, discussion, concessions, compromises, and creative critical thinking to coordinate a plan to improve the EMS system in New York State. It represents the work of the EMS Sustainability Tag, EMS disciplines across the state, from faith-based to municipal, independent, merged and consolidated to commercial, fire-based to hospital-based, collegiate and municipal, volunteer, career, and partially paid, have all come together to find solutions to the challenges we face. Our partners previously mentioned are now integrated into the EMS team. Let's see what we can do together. The EMS Sustainability Tag offers the following abbreviated 25 key recommendations. 1. By December 31st, 2023, the SEMSCO, the Bureau, and the Commissioner must create a comprehensive statewide EMS plan. 2. Increase the number of certified EMS providers in New York State by 10,000 by 2025. Fund a 3-year, $5 million campaign to promote EMS volunteerism and careers in New York State. 4. Engage stakeholders to address the decreasing pool of EMS providers to include pay disparities between EMS and other emergency services, fire and law enforcement, benefits, longevity, mental health, work hours, access to EMS education, and migrating from certification to licensure. 5. Engage New York State hospitals and the Healthcare Policy Council to strengthen relationships between EMS professionals and hospital systems. 6. Create and finance logistical and rationalized EMS system design through agency and CON consolidation that appropriately recognizes and includes existing CON holders and EMS market right holding municipalities at the county or regional levels. 7. Establish state-designated EMS leadership credentials similar to those recommended in the fire service. Fund EMS leadership development programs. 8. Incentivize implementation of tiered EMS response systems using certified first responder, basic life support ambulances, advanced emergency medical technician staffing, and paramedic staffed response units. 9. Establish, implement, and enforce agency performance standards. Measures should be transparent to the public and standardized across the state for comparative purposes. 10. Require PSAPs to engage local authorities having jurisdiction over EMS to collaborate in plans to assure dispatch of the closest available ambulance. 11. Through statutory and regulatory changes, implement regionalized EMS demand coverage, reliability standards, and policies that require a transport-capable ambulance be available to respond to calls for service within a clinically appropriate response time and level of service, include an agency CON-regulated corresponding areas of primary service responsibility using the following supply coverage reliability standards. A, in 2024, agencies will be required to respond to 80% of dispatched calls without mutual aid. B, 2025, 85% of dispatched calls without mutual aid. 2026, 90% of dispatched calls without mutual aid. And D, 2027, 95% of dispatched calls without mutual aid. 12, authorize and fund county EMS coordinators to facilitate coordination of EMS within their counties, to maximize economies of scale and ensure the timely delivery of EMS. Increase statutory authority of county EMS coordinators for managing EMS responses. 13, through statutory changes, ensure all 911 centers that dispatch EMS in New York State utilize a nationally recognized emergency medical dispatch protocol or equivalent to appropriately determine the resource needs and priority for EMS calls. 14, implement mandatory annual EMS agency participation in a statewide EMS cost reporting system that mirrors Medicare's ground ambulance data collection system for use in evidence-based adjustment of ambulance reimbursement under Medicaid, municipal subsidies, and other sources of justifiable revenues. 15, create statutory changes that establish and define EMS as an essential service in New York State and mandate that the service's beneficial stakeholders pay their fair share of the costs of funding it, including the cost of maintaining continuous readiness and reimbursement for any pre-hospital care that is rendered, including the actual care of transportation. 16, develop a state subsidy of grant program with support from the federal government to provide financial relief for EMS agencies to improve and meet quality response metrics as defined by the SEMSCO and the department. 17, fund a $36 million EMS sustainability grant program, distributing $2 million to each REMSCO. Initial grants would be awarded based on an approved plan with subsequent grants based on performance. 18, pass enabling legislation for mobile integrated healthcare and innovation like the Medicare pilot project on emergency triage, treat, and transport, ET3. 19, request SEMSCO to examine patient treatment modalities to assess whether procedures currently at the ALS level could be safely and reasonably moved to the BLS level. This would allow BLS agencies to more effectively treat and transport a greater number of patients when ALS care is not available. 20, increase and allow EMS course funding at all EMS levels and specialized EMS training from state EMS training fund to incentivize alternative delivery models, improve student enrollment, better compensate certified instructional staff, and coordinate geographic scheduling of classes to prevent overlap. 21, require all newly certified paramedics in New York State, effective 2027, to have a minimum of an Associate of Applied Science degree in paramedicine, grandfathering all prior ALS practitioners from this requirement. EMS field supervisors and advanced practice clinicians, critical care paramedics, flight paramedics, and community paramedics should have a minimum of a Bachelor of Science degree in paramedicine or a related field, and that EMS leaders, including administrators, managers, researchers, educators, should all have graduate level degrees. 22, amend New York State law to recognize EMS certifications as professional licenses regulated by the Department of Health and issued by the Commissioner. 23, require each hospital in New York State to have a staff member designated as the EMS Outreach Coordinator, Ambulance Discharge Coordinator to facilitate day-to-day communication, planning, and collaboration with ambulance services. 24, form a joint work group between SEMSCO, STAC, EMS for Children Advisory Committee, the Bureau of EMS, and the Department of Health Division of Hospitals and Diagnostic and Treatment Centers to review interfacility critical care transportation. And 25, fund personnel within the Bureau of EMS specifically to assist SEMSCO with leadership, administrative support, and process and policy execution. In addition to the key recommendations, the report provides detail on all of these topics. EMS systems in many areas of this state work well. While this report has not specifically drawn mention to these systems, it is critical to understand that these successful systems and the dynamics of them are included in our recommendations. The strong systems will serve as foundations and examples for others to follow. While some will take exemption to portions of this report, this is the work of EMS professionals who have debated and discussed multiple complex topics, all of which are interwoven. We cannot lose focus of our mission statement, which in part reads, the EMS Sustainability Tag will bring together a diverse group of EMS representatives from all disciplines across the New York State EMS community to discuss and study the issues, analyze, qualify, and quantify the challenges facing EMS, document the collective challenges facing EMS, and evaluate opportunities for system improvements. An emphasis will be placed on a future EMS system that is patient-focused, consistent, reliable, affordable, sustainable, efficient, socially equitable, safe and effective, adaptable, and innovative. The purpose of the white paper is to inform the readers concisely about the complex issues facing emergency medical services in New York State and present the TAG's philosophy on the matter. The intention will be to help the readers understand the issue, bring public and political attention as a movement to solve the challenges. The EMS system needs reform, and it needs it now. All discussions included a future system inclusive of existing CON holders. This is a call for you to prepare your agency to meet the public needs as we move forward. This is your opportunity to shine. Leverage solutions to allow you to strategically position yourself as a successful agency. In closing, please allow me to recognize a few individuals. Director Greenberg, for your leadership. These are challenging times with optimism of a bright future. Thank you for your unwavering support throughout this project. We challenged you, and you rose to the challenge. Thank you for having the confidence in me to lead this critically important project. It's been an exciting 17 months. I would never have imagined the progress, not only that the TAG made, but that EMS in New York State has made. Chairman Philippi, who I don't believe has made it back yet, for your support. The role of the SEMSCO chair is most challenging. You sit between the need of the public, the EMS community, and the political landscape. A constant struggle at a balancing act. Certainly, the project would never have been possible without your support. You too displayed confidence in my ability to chair the TAG. While I know there were times where you doubted my strategy, choice of words or topics, and those of the TAG, we persevered. Out of the gate, you questioned the number of the members of the TAG, 39 at first, wondering how we could get anything done with so many people. Today, my desire is that we have conquered your fears, that we have produced a document which meets the needs of the public, the EMS community, and the political landscape, and that we have started on a trajectory towards effective EMS system reform. Chairman McAvoy, for your support, your superior editing skills, and sprint to the finish line. At the 11th hour, you stepped in with vigor, enthusiasm, and a fresh set of eyes and tied the bow on our package. We, the members of the TAG and the SEMSCO, are forever grateful for the hours you dedicated to this project and so many other projects. Vice Chairman Al Lewis Sr. Not only was Mr. Lewis the first member of the SEMSCO to publicly comment favorably following my report, EMS in Crisis, but he also, too, immediately offered to serve as vice chair of the newly created TAG, which I graciously accepted, now with no regrets. As many of you so clearly know, Mr. Lewis's commitment to EMS for so many years is a reflection of his obligation to ensure reliable, affordable EMS coverage and that commercial providers be properly compensated for their expenses and ability to be sustainable in the future. While Mr. Lewis has retired many times from a variety of positions, he remains a strong force and advocate for EMS. Throughout this process, I would engage Mr. Lewis not only in challenging conversations, but we would share concepts and ideas, oftentimes discussions that were dynamic. Mr. Lewis provided constant encouragement for the work we were accomplishing and the strides we had made along the way. Mr. Lewis always stepped up to the plate to fill the role of chair as that became necessary. Thank you, Mr. Lewis. David Violante, my friend and colleague. For those of you who have not had the opportunity to work with David on projects or simply be engaged in critical thinking, you truly do not know what you are missing. David is a true leader in every sense of the word. He exemplifies the characteristics of a leader through his ongoing, continuous effort to have a positive impact on all aspects of EMS at local, regional, and state levels. David actively engages in conversation and always offers encouraging words. David eloquently discusses topics while considering all options. His patient-centered approach allows him to make decisions which are consistently in the best interest of patients. David is always professional. He constantly demonstrates his devotion to EMS and truly cares about all of those in the business. David and I share similar visions. Our teamwork has profoundly been demonstrated in the completion of many projects. David, while managing all of his additional responsibilities, took on as serving as chair of the agency subgroup. However, also stepped up to develop, implement, and analyze the sustainability tag survey. David always takes calls from me, and no topic is off limits. David, you are a true leader, an inspiration, and a great friend. Thank you for always being at my side. I've taken enough of your time. In closing, I want to thank all of you for your support throughout this project. My goal was simple: to develop effective, attainable EMS system reform that will ensure the timely delivery of the appropriate level emergency medical services to the public during their times of need. We are all in this together. It is critical that we have one EMS voice moving forward. Let's discuss, debate, and collaboratively work together on effective reform. Chairman McAvoy, it is with great honor that Vice Chair Al Lewis Sr. and myself present to the SEMSCO the New York State 2023 Evidence-Based EMS Agenda for the Future, written by the State EMS Sustainability Technical Advisory Group, a technical advisory group of the State Emergency Medical Services Council. Mission accomplished. Our work is complete. Godspeed.
Mr. Chair.
Mr. Chair, a motion to accept this report and thank the committee might be in order.
I'll second that.
You could make the motion, Beth.
Okay. I'd like to make a motion to accept the report of this committee and thank them for their work.
And I'll second it. All in favor, raise your hands. Any opposed? Leave the room. Carried.
And with that, Mr. Chair, I yield back the remainder of my time.
Mr. Lewis, legislative.
What a tough act to follow. What a great guy to work with. A great team that we put together and very successful. So a few things. First of all, I have a couple of motions. The first one is going to be rather simple compared to the second one. So let's kind of get that out of the way first. As you remember, Ann Smith brought up some concerns with rural areas and doctors being able to participate after the Zoom calls went away. So we started working on that. We started talking about the open meetings law, and I have Jeff Call to come up and talk about that for a minute. And I have a motion that we'll bring forward after he has the.
I will be brief. After some lengthy discussion as to what it would take to modify the open meeting law so that our physicians that could not attend a meeting could attend a REMAC meeting, let's be clear, we're not talking about SEMAC. There's a possibility, and what we're seeking in our motion is to have Director Greenberg reach out to legal to get an official opinion that whether a REMAC meeting, whether a physician could in turn log into a REMAC meeting. We believe that there may be an opinion there that it does not fall under the open meeting law, being that they are a subcommittee of REMSCO, and REMSCO is the actual committee that makes the final decisions. Again, it may be a long shot, but it's a long shot worth getting an opinion from legal before we try to convince 25,000 other people in the state that we want to change the entire open meeting laws for a physician in rural New York State. So that is what we've asked to motion forward, is for you guys to basically support us in having the Bureau look into legal and get an official opinion on whether the REMAC falls under open meeting laws and whether or not we could come up with a policy to allow physicians to log in remotely under certain conditions where they can't attend the meeting due to geography or their work schedules or whatever else. So that's the sum of it, unless there's questions.
Any questions? If not, do we need that motion read back, or do you have that, Valerie? Teresa has it. Oh, okay.
I have it on my phone.
You just gave me an opportunity, Al.
I'm telling you. See, I can't read that, so I have to.
Go ahead and read it.
Oh, thank you. So, the motion is to ask Director Greenberg to obtain a legal opinion as to whether or not REMAC is subject to open meeting law, as they are a subcommittee of the REMSCO. And that was the second in motion that came here.
Any discussion?
Can you use your microphone, please?
What he said was, let Dr. Langstrom suggest or to us that we include under the general construction law of New York State.
You should ask whether that falls under, whether that isn't against the general construction law as well.
Okay.
So both areas.
Okay.
Any other discussion?
So then are we amending the motion
to ask both questions?
I don't believe we can amend a seconded motion, can we?
Right, I don't think so. Well, friendly amendment. Welcome back, Dr. Langston.
It's part of a standard procedure that you have to use a microphone in
He's
order
been away
for...
a while. He's been away a while.
My microphone's not working.
Okay,
Now
fair
it
enough,
finally
there it
is.
is.
Someone can make a motion to amend. It's got to be seconded, voted on that motion, and then you vote on the whole thing.
Could I please move to amend the emotion? Motion.
Yes. You can move to amend the motion. What would you like to amend it to?
I'd like to amend the motion to include the question of compliance for the general construction law of the state of New York.
Need a second?
So is there a second?
I'll second it, Gandolfo.
Discussion?
Any discussion? Now you may vote. All in favor signify by raising your hand. Any opposed, same sign. Any abstentions? That motion carries as amended unanimously.
The motion has been amended.
No.
Now you're going to discuss the amended motions.
Right.
All right,
Turn
any
off my mic
discussion
already?
on the amended motion? If not, everyone in favor of the amended motion signify by saying,
Wait,
raising your
Steve
hand.
Katie can't get on mic yet. Hold on a second. He does want to comment.
Just real brief, I think this is a great idea, and I think it will help out a lot of the rural doctors.
Okay. Any opposed? Raise your hand. Any abstentions? It carries unanimously. Mr. Lewis?
You're getting this down pretty good now, sir. So, legislation did have a few items on the agenda, but the main thing we talked about was Part S in the executive budget. There was so much discussion around the room and in the halls and over dinner and every place about Part S and concerns about it. A couple of areas in specific is the districts, new districts, 10 new districts, how that would function. It doesn't report to anybody but the Bureau and those types of things. So that was discussed a lot. And I need to preface these comments, though, by saying, first of all, when Part F came out, there were a lot of things in that we just couldn't live with, but there were some that we liked. So when that was pulled from the budget, we were challenged by Director Greenberg. Okay, what do you want? What would you like to see happen? So Mark Deaver's team and the legislative team got together with a bunch of people. A lot of people had input on it. And we put together several requests that could possibly, if he pulled a miracle, get it in the executive budget for this year. Well, we got a lot of stuff in there we want. We don't really want to get into a position we have to fight to get this out of the budget, because I'm not sure there'll be patience for us on the second floor of the Capitol if we bomb this darn thing, to be honest with you. So we need to work toward getting from no to yes in some manner. So there was a motion on the floor that was made by Dr. Winslow that we need to look at this point in time and bring forward.
That's on your phone as well?
I would like to amend that motion.
Oh, wait a minute. Can't, but you can. You got to wait. It's my understanding, and I could be corrected by the guy over there that's got this microphone off, that he's going to have to tell us if we can amend the second in motion that came from the committee. I don't know that we can. Can we?
Yes.
First, you
just
got to
need to
bring the
confirm-
motion forward.
That's the other committee. Okay.
First, bring the motion
Okay,
forward.
I'll bring the motion forward.
Then
It's-
someone can make a motion.
It's in front of you right now. If you
I
could-
would
And it
read it out
reads-
loud for those of us who are challenged.
I can't.
Read
find
it aloud off your phone. Although
Yeah.
I'm younger than you, I can't see that far.
Jeez, I'm telling
Yes.
you. The harassment is funny. I can't find it on my phone now. I've had so
I'll
many
read it.
other
I'll
things-
read it then.
so
In
many
the
other
interest
things.
of moving along.
There you go. Thank you.
The Part S document shall be brought to the SEMSCO for discussion and approval with Section 3033 removed.
3033 is the district's component, the 10 districts that are being suggested in this packet. Those districts would function, the way it's written, autonomously and report only to the director of the Bureau and have no interaction with the REMSCOs or anybody else. That seems to bring a lot of the issues, the angst to it. So the motion's on the floor, and somebody wanted to make a amendment. Yes.
Doug Isaacs, I would like to amend that motion.
Yes, sir.
I'd like to make the motion to do an itemized review and not that one section. Itemized review of all the changes that were put into this document, Article 30.
We certainly can do that, but we don't have a lot of time here. We have,
Well, this
if,
is, sorry, this is such an important document, and we should have created more time to do this.
we have 19 days or the end of 30 days to make amendments to this Part S. And if, I'm not sure we can do what you're requesting and get it out to everybody and get it approved by everybody before we go any further. So I need your help with that.
It's just disappointing that we didn't, such an important document, that we had to come together as a body, did not take the time to review this as a group, now giving us only 19 days, to then now to have to submit suggested changes in the language, because we all agree we need to move forward, and there's a lot of positive things in this document.
Yeah.
However, there's a lot of things that need to be revised. We don't want to make it an all or nothing.
Well,
So-
You need a second before.
So
We're
it's-
having a discussion now. First, you have to second the motion. We're having a discussion on a motion that hasn't been seconded yet.
Well, the motion came seconded.
No, but he's having, the motion
Well-
that he's making is to modify what you brought. And he's discussing that.
Okay.
So let's first get a second to what he says.
Yeah, can I just ask one question, please?
No.
Yeah. So there.
You can't.
Okay.
Can't. Either that motion gets a second or it dies.
Well, if he can ask for a point of information if it's not clear what he's voting on. That's
Okay.
permitted.
Second it. Teresa Hamilton will
It's been
second it.
seconded.
Now we can discuss.
All right,
correct?
now it's seconded, so it could be discussed.
Can I talk about the timing before we go down? We got this information February 1st, when the executive budget came out, and we are not far down the road from that. And we're fortunate we had a chance at this meeting to talk about it at all. Had we not had this meeting, there would not have been a lot of discussion at this level. So I'm just concerned that we don't put something in there that's going to preclude us from possibly supporting everything in Part S except for if we want to pull out districts. And I'll leave it to you, sir.
I think it's more than just the districts. I mean, again, at this time, we were just getting this information and not be able to really go through these changes and go over the wording. To me, it's very concerning. It's just a push to get this through. So I don't think anyone would agree to do like an all or nothing on these changes, because there's a lot of good things in here, but not giving this body coming together and not be able to do an itemized review of these changes, I don't think is acceptable.
Yes, I'd also like to amend the motion to include rejection of all revisions to Section 3008, the application for determination of public need, because that's also a very big part of our discussion yesterday.
You surely can go back with another motion, but let's get this motion taken care of first. So,
That's fine.
okay, thank you for your patience. So, any more comments about the seconded motion now and the amendment to the motion?
I'd make a comment about the seconded motion that we need to be very clear that it is not our time frame to set,
It's not.
that we have no control over that time frame, that we have a document before us that we need to review and do the best that we can with what we're given. And if we can pull one section out that we find difficult, but proceed with the rest to try and make some changes in a very broken system, that might be in our best interests.
I'd also like to note that once this goes through, there is a gargantuan amount of work to put it into policy, regulation, and make it work for us. This is just the first step. We need to take that first step so that the Bureau and the SEMSCO can continue to do the work that's opened up by that legislation.
Correct. I'll just echo my colleague, Beth. We're in a very unique situation right now in EMS and I would say in legislation as well. For the last 2 years, we've had the attention of the executive branch of the New York State government, and that has not happened in the entire time that I've been on this committee. And there's certainly people around the room who have sat at this table much longer than I have, and I don't believe it's happened in their tenure as well. And I think Mr. Lewis mentioned that if we bark at too many of these things, we may not have another opportunity. Beth made mention that this is just the bottom of the framework. This is just the foundation. What we choose to build on top of this foundation is ours to build. I know that there's some concerns with some certain parts of this, but my overall thought is that if we start to nitpick at this, we're going to lose it. We have the attention of the executive branch that we have never had before. And that executive branch has the ability to fund us better than we ever have been funded before. And it's just something that I'd like all my colleagues around the table to think about while we navigate these motions and votes. Thank you.
Yeah, actually, I don't disagree with what you're saying. I think if you were to take out, this part about the districts, and if you were to reject, the revisions to section 3008 regarding determination of public need, I think we can get consensus to approve it.
Again, I'm going to respectfully disagree. There's some other, not major, but there's some, words matter. And so just to say, let's pass through, then we'll kind of read it now, pass it down, we'll read it later and build upon it, I think is not the best approach. There's some real concerns in some of the sections I have, not just the one that, we had talked about yesterday, but not to have the time to go through them or at least be heard and discuss it, because once you pass it, once this goes into law, it's hard to go back and change it. So to give it a short turnaround time with something so important, I just don't think it's acceptable.
Unfortunately, though, it's not our time frame, and I know we had the conversation, I forgot who it was with yesterday, but this may be our last opportunity to change anything. We have tried for years to get some bills through the traditional legislature process, and have not been incredibly successful. And we're stuck, unfortunately, with a time frame that's not ours. And I would echo what Jason has. They're not going to give us a third shot at the executive budget, and we're going to be stuck in the heck that we're in, the crisis that we're in, forever. And we have to, in some cases, accept the good with the bad. And I think spending some time going through it and sending technical edits to Director Greenberg instead of trying to chop, 2 or 3 sections of the document off is a much better avenue.
Mr. Chairman, could we call the question and the amendment to the motion, please?
I was just going to say that. Thank you, Mr. Duval.
But we are having a discussion here. I'm sorry.
A motion to call the questions in
So,
order. at
No
this
more
point.
discussion. No more
Okay.
discussion.
So let's call the question on the amendment, which is Dr. Isaac's amendment to this, to,
That requires a two-thirds vote. And call the question means you stop talking and you go to a vote.
we're calling the question on the
If you
amendment.
call the question on the amendment, means you're not going to, if it passes, there's no more talking about the amendment, but you have to vote on the amendment.
Right.
Right. I need a two-thirds vote
To call the question?
to call the question, yes.
Okay. So all in favor of calling the question, raise your
If
hand.
you want to go home, you call the question.
Any opposed to calling the question? 3. All right, so it has a two-thirds vote. So that ends the discussion on the amendment, and we will now vote on the amendment from Dr. Isaacs, which was to analyze it in sections. Is that correct?
Just do an itemized review.
An itemized review. So all in favor of that amendment to this motion to conduct an itemized review, raise your hands. All opposed, same sign. Any abstentions? So the amendment is defeated. Now, do we have more discussion on the original motion, or do we want to call that question?
We're back to the original
Ask if anybody
motion,
wants to
just
speak about
removing
it. Nobody wants to
3033.
speak about it, there's no point in going on.
All right, let's vote on the original motion.
Can I amend the motion? To include the rejection of the revision to section 3008?
You can propose another amendment if you
Okay.
want.
Okay.
That's in order. Is there a second to that? Seconded by Mr. Lewis. So discussion on the amendment to include section 3008.
Could you clarify what section 3008 pertains to?
That refers to the certificate of need process.
Oh, that pertains to applications for the determination of public need. That would take the REMSCOs out of the process, which is what we reject.
In that, and forgive me, I forgot exactly what line it is, but in the 3008 change, it does say that the SEMSCO shall promulgate regulations on the process for CONs. There's absolutely nothing preventing the SEMSCO from saying that CONs can be handled by the REMSCO through a regulatory process. Correct me if I'm wrong on that, Mr. Director.
That's correct. I'm not the director, but he's sitting next to me. Beth?
We also said in the legislative subcommittee meeting that, with regards to this, that there's nothing that says that the region cannot have initial review and recommendation powers.
I don't know why we want to make any change at all. Okay, I don't see the need for a revision. Okay, this process worked very, very well, okay, with the REMSCOs. Sort of like a solution in search of a problem. Okay, the process has been fair, it's worked, okay, it's been very efficient, okay, it's been highly transparent, okay, it's so efficient, okay, the whole process of going from a public hearing, okay, determination by the REMSCO is done within 90 days. If you want to improve the process, let's improve the process for the appeals. It shouldn't take 1 to 2 years to come back to the SEMSCO. Okay, that's the problem here. Okay, other than that, okay, I can't see any reason why we want to make any revisions.
There's already a tag in the systems committee reviewing 0606 and the CON policies and procedures. So the changing is already underway. The discussion of the changing anyway is already happening at the systems level. in a 0606 review tag. Correct me if I'm wrong, Mr. Devers, but that's the charge of that tag, correct?
That is my understanding.
Mr. Hudson?
So I think there's two different topics for discussion. The one is the districts, which it seems is almost unanimously hesitant to be included without further exploration. I think the more contentious, or possibly the one we can actually find some common ground on, is the CON question. And to me, that goes to intent. I don't know what the intent behind the districts is, so I'm opposed to it until that's explained to me further. To the CON, I think it might be a simpler answer. So is the intent of the CON amendment as proposed in the budget to move the deliberations to the state council instead of having those deliberations done at the REMSCO, simply to expedite the process? As Dr. Krupe is saying, we still have the transparency, but an acknowledgement that, as we've seen all too often, the deliberations go on, taking up a lot of time and energy on the regional level, just to almost invariably nowadays end up here at state council anyway. Is the intent here to actually streamline that process, to, since they're going to end up here anyway, to just start them here? And I would speculate, if my reading of it is correct, that it also expedites it for both parties if there is a contentious CON action, where if it starts here at state council, it then ends at state council, since there is no appeal, which then forces it into the judicial realm, which should, I would hope, prevent a lot of the arbitrary nonsense that's gone on about this. If you know you're going to end up in court because there's no place else to go, then it should stymie a lot of the nonsense. And if that's the intent, I can get behind that.
Yeah, I just don't know, when it takes 1 to 2 years to get through an appeal, how the state is going to officially process, the original request, for CON. And for me, actually the biggest thing, is the transparency. When it starts at the local level, there's a public hearing. The applicant can bring whoever they want, in support of their application. Likewise, those in opposition can do this in a very, very highly public way. Have that opposition known, the reasons why. A recommendation gets made, it goes back to the regional council. Who knows better, than the regional council, local conditions, and the conditions, that require certification, for need. And at the end of the day, if there's disagreement, with the determination of public hearing, and there's disagreement, by the REMSCO, with that decision, or someone's not happy with the outcome, they can appeal it. But it's a very deliberative process, that is highly transparent, and I don't believe that the changes that we're talking about, will be as transparent, as they could be, as they are right now. And I think, I think in general, I think the public's pretty unhappy, with government, and a lack of transparency. So why do we want to go there?
So
Mr. Chairman, could I call a question on this amendment to the motion, please?
There's a motion to call the question on the amendment. All in favor of calling the question, raise your hand. Opposed? So it looks like the question will be called, so we'll vote on the amendment to eliminate Part 3008. All in favor of adding that amendment to the motion, raise your hand. 1, 2, 3, 4, 5, 6, 7, 8. Keep your hands up for a minute, just so I can count them. 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, all opposed? Okay. Looks like the amendment is defeated. So would we like to vote on the original motion? Yes? All right. All in favor of the original motion, Raise your hands. All opposed to the original motion, same sign. Any abstentions? All right, so the original motion passes.
Well, that was fun.
Yes.
So let's talk about that for just a minute. So now a motion comes from the SEMSCO to support Part S absent districts. That goes to, as I understand it, to the director of the Bureau. He can discuss that. Well, he told me there's no magic to change the governor's executive budget, but he can push this information forward and express that we are dissatisfied with districts in there and we really would like to see it removed. And maybe there should be another motion. If it's removed, we ought to say that we'll support Part S. But that may be beyond what we can do here. But I just wanted to explain what happens here now. We're not sure we're going to win this thing, but we're asking though that this show up in the 30-day amendments. This is a challenge also because the 30-day amendments are due on March 3rd. So there is a time frame with this too. If it's not seen in the 30-day amendments, it would not be seen until the one House bills come out or whatever. So, and I don't know how we communicate with each other. Okay, that's removed and we can support it. All of this started because there were several people in this room expressed that they are going to fight to get Part S out of the budget. And adamant about it if there weren't some changes. And that's what we're trying to do because we don't want to lose this information. So, is there any other discussion necessary before my comments in the legislative committee is done?
Mr. Lewis?
Yes.
If you don't mind. So, for starters, I just want to say thank you. Thank you for the discussions that are here. Thank you for the discussions that have happened over the past couple of days, the feedback. And to say to you, yes, you're correct. You know, from these things and from the motion and the things that move forward, I have the ability to share that information up within my organization, who then shares it up beyond that. What happens in the governor's budget is the governor's budget. But the ability to collaborate and talk and share those, those concepts from now until whenever someone will listen to me in the process here, including, Doug, any other comments, that come through or things that you do, have a further review, including, what it sounds like here, and I think we even heard over the past couple of days, the inclusion of the REMSCOs, possibly, in the CON process or 3008, the kind of feedback from so many different perspectives, which is critical and important. I think the intent for 3008 too was to create, I think what Mr. Lewis has asked for years, which is what is the definition of need? What is, how will something be determined? And Mark and his team, Mark Devers and his team working on that. And taking that work and having it to have the option or the ability, as was spoken by other council members, related to putting that into reg and having a standard for it, and these are all the comments and the feedback and the program agencies, even in some cases, and some of the things that were brought forward, where it's a word that was changed from one to the other, but people are much more comfortable with the other. Well, that's important to hear, and those are things that I can bring back. Those are things that I can, help with. Now, does it change it? I don't know. But as we saw last year, where everything was pretty much written to SEMAC, and, in other edits, it came to look as everything being, back to where it was with SEMSCO, those were, not easy things or single conversations saying, hey, can we change this? They were positive communications. They were feedback from this group. We saw it even more through Mr. Lewis and your review of things and looking at where things came out. There's a lot of really good things in here. But there's also some things that all of us will have to work on some compromise for. They're not exactly what I want. They're not exactly what this person wants. And that's part of this process. And that's part of the importance of what we go through with this process. But being able to move and you know, to look at Chief Benedotti and the report that came out from the committee and have these changes in statute hit 15 of the 25 points, to allow 15 of those 25 points to actually be achieved is pretty remarkable. And I don't know how we necessarily would be able to achieve that without some of these changes, or what that time frame might look like. And like Beth said, the time frame of this is still going to be prolonged. This is only step one, and then, you know, for this council to look at regulations, to look at, you know, what those next parts are. Also, you know, to have the conversations, to make sure, you know, people are having accurate and factual conversations. And I sat in one meeting, and they turned to me and said, well, you know, I was told before coming to the meeting that this would eliminate REMAX. It doesn't even talk about REMAX. But somehow or another, that was, you know, that definitely this eliminates it. You know, and making sure that people have good and factual information. And hopefully, you know, everybody who's participated in the conversations through the past couple of days are able to, you know, share that information, make sure that it's actual information, factual, and if there are other parts that are the unknowns, that they come back and they ask, and that we work to make sure that that is clarified. So I just want to say thank you for everyone over the past couple of days. Hopefully the next couple of weeks, the continued conversation, support, and really the movement to, you know, move a lot of really good things forward. Thank you.
I'd close by saying, if something like this is considered again, it would be really nice to have it here to talk through it before it gets to the executive budget. I know that's almost impossible, but you never know what may be coming down the pike. We'd like a chance here to talk about it before it goes there. Thank you. I'm done.
Thank you, Mr. Lewis. It could be no more timely than to have the Safety Committee report now. Mr. Knoll.
Thank you. I'll be very quick. We continue to review policy 0013, continue to work on the provider resiliency project, also working on the management of escalation tactics, and also looking at a guidance document for hazardous operations. Hopefully we'll have some more information on that in the upcoming months.
Any questions for Mr. Knoll on the safety report? If not, we'll move to Mr. Violante for the quality metrics report.
Thank you. In the interest of time, I'm going to defer the presentation. I think everybody here has seen it in the SEMAC, and so I'll take any questions on that, knowing that the work of the committee was to develop the quality improvement manual and quick start guide. Those were delivered at the last meeting and presented. We have given a lot of folks the ability to take a look at it. We've got a lot of great comments back. Thank you so much for those. And have the opportunity for folks to have the ability to look at their own data at their agency. That continues throughout these last 2 days. We've had the data informatics team available outside to walk people through what that looks like on biospatial. And we will continue to do those things. Our next steps are to look at quite a number of quality measures that we would want every agency to look at the statewide level, and then from there bring those outwards into some other measures that would include bundles and from other spheres of influence like STAC, EMSC, cardiac, stroke, etc., and then on from there to other agency levels for broader pieces of data as well. And so that's the work of our committee to this point. I want to give a huge shout out to the quality metrics team. They have done a tremendous amount of work, meeting every month to develop this manual, quick start guide, and to the data informatics team for the ability to get information out through image trend and biospatial. I think everybody here is absolutely going to love biospatial because we will take all of these quality metrics, put them in there so that you merely need to access it and look at them.
And we're hoping for a rollout of that in May. And we will continue our consternations of what quality metric components should be developed for the state level and bring those to this body in May. At this time, I would like to ask if we could approve the quality improvement manual and quick start guide.
Jason Haig, I make a motion to approve the quality manual and quick start guide as submitted by the Quality Metrics Committee.
Teresa Hamilton, and I'll second it.
So we have a motion on the floor and a second to approve the quality improvement manual and the quick start guide, which I think all of you have seen since it's been onboardable for quite a while. Any discussion on it? Mr. Hudson?
Just as we don't miss an opportunity, as not everyone's here in person, and it's only today, right now, that's being recorded and televised to those that aren't in person. Could I ask the Bureau, would it be proper that this presentation be done on the next statewide provider and leadership call so that everyone actually has a chance outside this room to see it? And I'm trying to get ahead of the unfunded mandate, who's to force this down our throats. I'm not doing that. I don't care if they give me a button that it's a one click. I'm not clicking it. You know, we've sort of done these things in the past, and maybe we can be smarter about it.
Any concerns, complaints, or issues of pressing the one button, I've already spoken to Dave, and he has nominated you to handle all those. We will give out your personal email address, and they will all come directly to you. No,
I'll
I
second
think that's,
that.
Yeah.
I get the regional death threats, so I'll take the state ones too. So,
no, I think that's.
Yeah.
I think
Come
that's
on
an
down. It's beautiful downstate. Come on down.
I think that's an excellent opportunity. I would say I think the brief one should be at at a leadership call, especially being how brief that it really was. And then I also think that we can do a Vital Signs Academy one that can record and live on Vital Signs Academy. For anyone who isn't able to make it. I will also say for anyone who is watching who's unable or it wasn't presented now, it's also up on the recording of SEMAC, which I believe gets posted within the next 48 hours. So that will be up there too. But yes, absolutely, we can take action on the other two.
Dr. Redlinger?
So I'd like to just make a comment about the way in which we approach this that I think is important for people to hear, right, before to kind of head off some of that discussion that might come down the road. But again, there's been the quality manual and the quality quick start guide are really just resources for people to use in their system and agency. It's not a mandate to do anything in particular, but it is a guide to help agencies to do better quality improvement and take better care of their patients. So that's one thing that I would say for that piece of it. But the other piece is the quality measure piece we're going to be discussing. And I think that it'll be important to have people's feedback and input on that, and anybody who wants to should be able to give feedback on those.
Good stuff. All right. Anything additional, Mr. Violante? Could I ask you to give a quick synopsis of the iGel project status?
I'd love to. If it's possible, we could take the vote first.
Yes, call the question.
All right. I didn't take my Enzimet this morning, so. All in favor of approving the quality improvement manual and the quick start guide, please raise your hand. Any opposed? Same sign. Any abstentions? All right, that carries unanimously. Good thing I have cues here. iGel.
Thank you. Yes, an iGel update from the Hudson Valley region. We have more than 25 agencies that have applied and are approved to go through the training process and are somewhere in that training process now, which includes the ability to do the training online through Vital Signs Academy and do their didactic reviews locally and or to do the training through one of their local CICs using materials that were provided to them that were approved by this body and through the SEMAC, and additional materials from the manufacturers, and an absolutely wonderful presentation, BLS use of CPAP from Dr. Dorsett and Dr. Jeremy. So I appreciate those as well. And so fairly soon, we will have a number of those agencies actually starting this and using this out in the field, and we'll collect that data. The DI team has been really good in ensuring that data will come from agencies to program agencies, the state, and to the region so that we can start tracking these.
Good. Any questions? Don, is your mic hot for a reason?
Probably, but not now.
All right. We'll move along to EMS innovations. Let me just remind people who are the ones sitting at the table here, the Quality Metrics Committee needs more SEMSCO members. So if you would like to join that committee, let me know. And if not, I may let you know. So moving on to innovations.
Thank you, Mr. Chairman. The EMS Innovations Committee has no seconded motions to bring before this body. We had a phenomenal meeting yesterday of the EMS Innovations Committee, and Director Greenberg and his staff worked to get in some of the ET3 providers throughout the state. Those being AMR Buffalo and Rochester, Colony EMS, Mount Sinai EMS, FDNY, Northwell Health, Mohawk Ambulance, and Clifton Park Half Moon. And we had a discussion that was a very well-spent hour on the successes and trials of the ET3 program. A lot of good information came out of that. And one of the biggest take-homes is education to the providers and, getting them to be able to buy in to doing this this new approach to, telemedicine, treat in place or alternative destinations. And the other shortcoming that everybody identified unanimously was public education. And we're going to work with the Training and Education Committee and work on some information that can be given to probably state public health and then down through the county public health systems to help with public education on the concept of alternative treatment and destinations for patients. And the last thing we did at our meeting was started a tag to brainstorm what mobile integrated health and community or community paramedicine will look like in New York State, which, interestingly enough, with the timing, is both in the EMS Innovations, the EMS Sustainability Tags white paper, as well as part of Part S in the governor's proposed budget. So we're going to work on that. Just because it gets approved, that doesn't mean anything if we don't have a definition and a scope approved. So we're going to get to work on that, and that is the end of my report, and I'll take any questions.
Any questions for innovations? If not, Amy, do you have anything you want to quickly review for EMSC? Oh, well, negative. So under old business, we have a couple tags that I just want to call on. DEI, Dr. Raybridge, do you want to give a little synopsis? Okay, he defers to his colleague Jared.
The DEI tag has worked with the state to develop a survey. It's been posted on Boardable. We're open to comments. We based this survey off of a survey developed out at Stanford focused on diversity, inclusion, and belonging, harmful experiences, and open-ended comments that we will work with the state to distribute. We have had 4 individuals who have identified themselves as being interested in joining the DEI Technical Advisory Group. Those CVs have been forwarded, so they will be joining the DEI tag, and we will continue to work with the state to figure out ways to make sure that we distribute the survey. There have been some initial comments about the length of the survey, and it does dig into some challenging issues. If the answers are no to the questions, it takes about 2 minutes to answer the survey, if less. If the answer is yes to those questions, it asks significantly more in-depth questions. When the group at Stanford put this survey out to their entire population of, I want to say it was about 40,000 members of their community, they had 15,000 responses. So I think as a demonstration that if people are interested and invested in it, and have thoughts, they will still continue to respond. They implemented their survey in 2021. And so it wasn't too long ago. And since it was, it seemed like a valid and reliable instrument to use, developed in a sound way, we based it off of that.
And you're looking for individuals to complete that?
Yeah, so it would be, we're going to work with the state to figure out the best way to distribute it to the individual providers.
Any questions? If not, Mr. McCartan, do you want to give a little report on the program agency tag?
Sure. Sorry. Don's over here barking in my ear.
It's hard to sit next to Don Hudson.
Well, somebody's got to do it. I'll take one for the team. So as I guess as a debut of our status as a tag now, I just wanted to report that we had our meeting on Monday with members from the Bureau staff there. We also had members from the Finance Committee. Our illustrious new chair was also in attendance. And some of the things that we discussed with all those individuals were things related to finance, as was eloquently put by Mr. Kroll. We discussed issues that, or concerns and support of things that we had in the Part S. Mr. Brody and his team came out and introduced us as program agencies to the biospatial, as well as had discussions related to a project that he's rolling out to get program agencies more involved in audits of PCRs making it to the state. The last thing that was discussed at our meeting was Crystal Peregrine and Amy Eisenhower came out under the umbrella of Coverdale and had some discussions related to stroke, particularly to times related to stroke as far as notification to the hospital and some other QI measures, and wanted to open the door to ensure that we continue to communicate with them on these measures as well, hopefully to improve some stroke care within the state. Other than that, that was about all we discussed.
Okay. Any questions for the program? I skipped over STAC, the State Trauma Advisory Committee did not meet, so we don't have a report from them. They'll meet again on March 1st. We have anonymously mailed them a bottle of TXA. And I'll move on to new business. Any new business?
Hi. As the newest member of SEMSCO, I just want to first say an extreme appreciation and thank you for that white paper you guys produced. Incredible. I can't wait to run around and share it and take some of the credit. That being said, what stood out was, and I'd be remiss if I didn't bring this up, because during the eloquent presentation, number 15, I wrote it down on his 25 bullet point, was the mention of essential service as a goal. I don't know what year that was on there, but as representing, Westchester County, there's a big push in Westchester for that bill. It's facing some difficulty. I had a call with a state senator last night, and basically the word is they need support from beyond Westchester. So I think most of us know of the bill, clearly, and the subject matter hitting the white paper as well on number 15. And I was asked to get the word out further so that the senators and assemblymen who bring this forth could get more support from their colleagues because it is fraught with some challenges, at the committee levels.
Thank you. Amy Eisenhower, do you want to give a synopsis of EMS for Children?
So briefly, Dr. Cooper had to go catch the train, so I will give you a synopsis. Last week, we had our EMS for Children Advisory Committee meeting. As he mentioned earlier, we had some discussions on trauma triage in conjunction with STAC, and we're working towards building some documents for that to clarify the changes that had been made. We also have a pediatric education work group. Some of the members from SEMAC and some of the members in this room also joined us. And like the EMSC agitation group, we found that education on de-escalation and in general psychiatric health of pediatric patients was lacking. And that will be our heavy focus, and so that is ongoing. We also, there was a demonstration earlier on safe transport of newly born patients, which has grown out of the safe transport of pediatric patients, as that is the question that is often mostly asked. So there will be continued work, obviously supported by SEMSCO, EMSC Federal, HRSA, et cetera. And education for that. The EMSC survey. So I just checked, we're at 30% of the agencies in New York State. So EMSC Federal has an annual EMS survey. Many of you, I'm sure, have heard me for months asking, have you done your survey? So I would ask everybody in here, reach out to your agencies if you're a medical director or a program agency director, or if you're out there in TV land. If you're in EMS leadership, go to emscsurveys.org. If your agency is still listed, it means nobody has done your survey. So please complete your survey. It is very quick, about 10 minutes. And it's related to pediatric emergency care coordinators, whether you have one or not, and some information on, what could help you have one, and also skills training at your agency related to pediatric calls. And so for reference, that doesn't come to me at the Bureau. That goes right to the EMSC data collection point. And I only see collected, cleaned, de-identified data. All I can see is if you did your survey or not. So I don't see any of your comments or anything. It's not, a punishment or punitive. It's really just so that Federal can develop good education and we can help distribute that and develop good education here in New York State to benefit your agencies and the kids in New York State. And I think that's everything.
Thank you. Any questions for Amy? If not, I'll entertain a motion to adjourn.
1 second. I'm sorry, I have
Ms.
a
Hamilton?
question. Yes, sir. I have 2 questions. It's a one question, 2 parts. I will start by saying I am more than happy to help out wherever I need to, if needed, so as not to be run over by the bus. I'm just wondering if we can, I like to thank Mike for working on the update on the committee list. That was one of my questions. It's awesome. Can we also work on getting an update on the term expiration dates for the members? And lastly, I'm wondering, as far as the vetting process is concerned, I know from the volunteer sector, we've already chosen our alternate. And I don't know what the process is as far as vetting alternates. My concern about it is, for example, if I'm unable to be here at the meeting, my alternate can be here, but truly doesn't have a incentive to be here. He doesn't get the information. He doesn't have the vote. So he's just like a warm, fuzzy body. If he was able to to be vetted and have the ability to vote and have all this paperwork ahead of time, it could also be the difference between having a quorum and not having a quorum. So I just was wondering how that works.
Well, currently, alternates aren't vetted, and even if they were, they can't vote. So they can attend meetings in place of the person who's on SEMSCO. And I think we could take a look. Correct me if I'm wrong.
I believe, yes. I think when we looked at redoing the bylaws, and correct me if I'm wrong, Dr. Langston, we did define the it was already defined in there as to what the duty of an alternative was, and then I believe it doesn't give them voting power. So
I will say, in regards to materials and things, I mean, that would be a fairly quick change at the discretion of the chair to add them to boardable and the discussions, and so they could be part of the thread. I mean, I don't, they are, as an alternate, a part of council. Really, the only restriction that would be there is voting, because they're not vetted in the bylaws and everything else. But as far as materials and boardable and discussions and any of that, again, I would say that would be at the discretion of the chair, but absolutely.
So
And part the reason, not to cut you off, but part the reason why they're not included in the SEMSCO list is when we first started it, it had a capacity and we couldn't add more people to it. Well, technology has changed quite a bit. We have Al Lewis using his phone to read things. And so we can certainly accommodate them in boardable.
Okay, and again, not to be, argumentative or anything, but, and especially this late at night, part of my question is there an ability or a desire to potentially look, and I know we're redoing bylaws and stuff, is there a need or a desire to look at the potential of allowing the alternate to have that voting capacity if the seated person is unable to be there? In my humble opinion, as an alternate, I don't have a reason to be here if I can't vote in place of the person who I'm alternating for.
I think I would also bring up, and I don't know in regards to your alternate or any of them, but an alternate would be an ideal person to also be a committee member. And to, I'm not saying, vetted or not vetted, they have an opportunity to participate in the committee. So you talk about, not having, well, what's the purpose for being here? They could be a committee member and to, provide value, even on days you are here, but in a committee maybe that you're not a part of or don't have the same passion in, or fill in the blank. So I think there is additional value. We just need to, work on what that looks like.
I believe we discussed that in the bylaw discussion as well, about adding them to the committees and allowing them to serve on committees. It just sounds vaguely familiar. I apologize if my memory is not 100%.
Additionally, an alternate is responsible, if the delegate can't be there, to carry the messages back to their constituents.
Yeah, but on the other side of that, I can sit home and watch it if I can't be here and bring that information back. It's a mood issue, I guess, but it's just kind of, to me, it just seems relatively important that if I'm going to make the 2-hour drive to be the alternate, to put the time in, to, pay attention, be committed, throw me a bone, let me vote.
So I think in this particular case, let me also go back, and I'm not even going to look to my right because they will absolutely just stare me down. I'll go back and look at, what it looks like, what that, if it's even an option. It might not be, just in the process of things, it might not be an option to be an alternate. But let me at least get you the facts. I will tell you, and you see the problem with vetting today and in just how long a process takes. If we double the number of people then who have to be vetted, I fear a little bit that will just prolong the process of the primary person who's, trying to fill a seat. And so that becomes, a secondary issue or a second thing that we should consider. But let me at least get you the answer of if it's even an option and, what the statute and the law and the bylaws, might be behind that, and then make an informed decision from there. Ironically, no, and that's an important part too. So, and what she said was then they'd be ready to go into a seat. Unfortunately, whether you're seated or you're up for a new seat, it doesn't change the vetting process. So we have people who sit on both committees and they're like, oh, well, this should go quickly. It's the same process, whether you're already vetted on one council and you sit on another, or you sit on something completely different in the department. So I wish I could say that was the case, and if it did, I think that would add a different level of, possibilities to it. But unfortunately, it doesn't. But let's look into it and at least get you an answer.
The other thing that would be very helpful to new members, being a newer member myself, even though I've hung around for years, is to make sure that each new member receives the current set of bylaws. I don't know what the bylaws of this organization are as they stand at this moment.
I will be happy to post them on Boardable tonight.
And people can make suggestions when the bylaws do come here, as much as I don't want to postpone this yet further, people are allowed to modify the bylaws. In other words, it can be a vote just like anything else. And then it gets read another month, but everyone who's sitting around the table has a right to say, I want the bylaws to allow alternates to vote in the absence. I had some suggestions as well, and hopefully they'll get passed. And by the way, about the vetting process, I'm vetted by the CIA. That did not stop a huge, long process to be vetted for SEMSCO.
It's part of the reason why it took so long with you.
I understand. Actually, the cop was surprised. What are you doing on the CIA's list?
We make a note that
I
think on the topic that Terry brings up, though, when I was an alternate, one of the biggest problems was when you would come to SEMSCO in place of the primary seated member, you're on the hook for the travel expenses, the room, and all that. And I think another concern would be if the, if the alternate's not here, why can't they submit for, not if the alternate's not here, but if the primary's not here, why can't they submit for that reimbursement as well? And I think that's just another.
I can turn and say we can look into that, and I think that, again, might be a more fixable thing, in regard to where it's reimbursement for one person who's participating, who's a member. What I think, like you said, I think it'd be a problem if it was both. That would be a problem, but
Or
one
get
who's
in
serving
on
us.
the hotel reservation list if you
Now
know
you're
that-
just getting really, come on.
alternates currently can put in for reimbursement when they're in place.
Note the problem has been solved already, and how quick that was.
Well, no, because my alternate's not vetted yet, so.
Travel's covered now.
Okay, so my alternate would be covered for, go ahead, Val.
Terry, if you were not able to come to a meeting and your alternate came in your place, even though he's not eligible to vote, his travel would be reimbursed. Just the travel per diem, the same thing that you would get, that alternate would get, as long as you were not here. Room as well. You're welcome.
That's the quickest answer out of the state ever.
Motion, I don't think I can make it, but motion to adjourn based on that.
I was just going to do the same thing. Motion to adjourn, Mr. Chair.
Second.